Chapter 124 Polycystic Kidney Disease. Polycystic kidney disease is a genetic condition where the healthy kidney tissue is replaced with many fluid-filled cysts. The enlarged kidneys may be palpable on examination of the abdomen. Polycystic kidney disease leads to renal failure. There are two types of polycystic kidney disease: autosomal dominant and autosomal recessive. The autosomal dominant type is more common. Let's start by talking about autosomal dominant polycystic kidney disease. The affected genes in the autosomal dominant type are the PKD1 gene on chromosome 16 in 85% of cases and the PKD2 gene on chromosome 4 in the remaining 15% of cases. There are extrarenal manifestations, meaning features that occur outside of the kidneys, and these include cerebral aneurysms, cysts elsewhere in the body, including the liver, spleen, pancreas, ovaries, and prostate, mitral regurgitation in the heart, and colonic diverticular. Complications include chronic loin or flank pain, hypertension or raised blood pressure, gross hematuria, meaning bright red blood in the urine, which can occur with cyst rupture and usually resolves within a few days, recurrent urinary tract infections, kidney stones, and end-stage renal failure occurs at an average age of 50 years. Next, let's talk about autosomal recessive polycystic kidney disease. The autosomal recessive type is caused by a mutation in the polycystic kidney and hepatic disease 1 or PKHD1 gene on chromosome 6. The autosomal recessive type is more rare and severe than the autosomal dominant type. It's often picked up on antenatal scans during pregnancy with oligohydramnios, which is a reduced amniotic fluid volume due to reduced urine output by the fetus with diseased kidneys. Oligohydramnios leads to underdevelopment of the fetal lungs, described as pulmonary hypoplasia, and then respiratory failure shortly after birth. Patients may require hemodialysis within the first few days of life. They may have dysmorphic features such as underdeveloped ear cartilage, low-set ears, and a flat nasal bridge. End-stage renal failure usually occurs before reaching adulthood. Finally, let's talk about management. Ultrasound and genetic testing are used for the diagnosis. Tolvaptan, which is a vasopressin receptor antagonist, can slow the development of cysts and the progression of renal failure in the autosomal dominant type of polycystic kidney disease. Tolvaptan requires specific criteria and specialist monitoring. Management may involve antihypertensive medication for hypertension, for example ACE inhibitors, analgesia for acute pain, antibiotics for infections, for example urinary tract infections or cyst infections, drainage of symptomatic cysts by aspiration or surgery, dialysis for end-stage renal failure, and renal transplant for end-stage renal failure. Other management steps include genetic counseling, avoiding contact sports due to the risk of cyst rupture, avoiding nonsteroidal anti-inflammatory drugs and anticoagulants, and MR angiography, or MRA, can be used to screen for cerebral aneurysms. Chapter 97 Reactive Arthritis. Reactive arthritis involves synovitis, or inflammation of the synovial membrane, in one or more joints in response to an infective trigger. Typically, it causes acute monoarthritis, affecting one joint, most often the knee, and it presents with a warm, swollen, and painful joint. A significant differential diagnosis is septic arthritis, where there's an infection inside the joint. Patients with reactive arthritis do not have an infection in the joint. The most common triggers for reactive arthritis are gastroenteritis or sexually transmitted infections. Chlamydia may cause reactive arthritis. Gonorrhea typically causes septic arthritis rather than reactive arthritis. Reactive arthritis is a seronegative spondyloarthropathy. There's a link with the HLA-B27 gene. It's more common in patients with HIV, and HIV needs to be excluded in patients who present with reactive arthritis. Let's go through the associations. Reactive arthritis is associated with bilateral conjunctivitis affecting the eyes, and this is non-infective conjunctivitis, anterior uveitis, which also affects the eyes, urethritis, which is inflammation of the urethra, and this is non-gonococcal, meaning it's not caused by gonorrhea, and circinate balanitis, which is dermatitis to the head of the penis. A Tom tip for you, the classic triad of conjunctivitis, urethritis, and arthritis are remembered with the mnemonic can't see, pee, or climb a tree. Finally, let's talk about management. Patients presenting with an acute, warm, swollen, painful joint need to be treated according to the local hot joint policy. Septic arthritis needs to be excluded. Antibiotics may be given until septic arthritis is properly excluded, as this is a serious life-threatening condition. Joint aspiration is required. This involves taking a sample of the synovial fluid from the joint, which is sent to the lab for microscopy, culture, and sensitivity testing for infection and crystal examination for gout and pseudogout. Management of reactive arthritis after septic arthritis is excluded involves treatment of the triggering infection, for example chlamydia, non-steroidal anti-inflammatory drugs or NSAIDs, steroid injection into the affected joint, or systemic steroids may be required, particularly where multiple joints are affected. Most cases of reactive arthritis resolve within 6 months and they do not reoccur. Recurrent cases may require DMARDs or anti-TNF medications. Chapter 98: Ankylosing spondylitis. Ankylosing spondylitis is an inflammatory condition affecting the axial skeleton, mainly the spine and the sacroiliac joints, causing progressive stiffness and pain. It's also known as axial spondyloarthritis. It's part of the seronegative spondyloarthropathy group of conditions that also includes psoriatic arthritis and reactive arthritis. The main affected joints are the sacroiliac joints and the vertebral column joints. Inflammation causes pain and stiffness in these joints. It can progress to spine and sacroiliac joint fusion in advanced disease. There's a strong link with the HLA-B27 gene, and around 90% of patients with ankylosing spondylitis have this HLA-B27 gene. It's thought that less than 10% of people who have the gene will go on to get ankylosing spondylitis. The condition is more common in men, but women can also be affected. Let's talk about the presentation. The typical presentation is a young adult male in their 20s. Symptoms develop gradually over at least 3 months. The main presenting features are pain and stiffness in the lower back, and sacroiliac joint pain in the buttock region. The pain and stiffness is worse with rest and improves with movement. The pain worsens at night time and in the morning, and it may wake them up from sleep. Patients will wake up with stiffness that takes at least 30 minutes to improve once they get moving. Additional symptoms and problems include chest pain related to the costovertebral and sternocostal joints, enthesitis, which is inflammation of the entheses where the tendons or ligaments insert into bone, dactylitis, which is inflammation of an entire finger, vertebral fractures presenting with sudden onset new neck or back pain, and shortness of breath, which can be related to restricted chest wall movement. Let's talk about some associations. There's a long list of associated conditions, and the key ones can be remembered with the 5 A's mnemonic: anterior uveitis, aortic regurgitation, atrioventricular block or heart block, apical lung fibrosis, which is pulmonary fibrosis of the upper lobes of the lungs, and anemia of chronic disease. Next, let's talk about Schober's test. Schober's test assesses spinal mobility. With the patient standing straight, the L5 vertebra is located and a point is marked 10 centimeters above and 5 centimeters below this level, 15 centimeters apart from each other. Then the patient bends forward as far as possible and the distance between the points is measured. A length of less than 20 centimeters, meaning a 5 centimeter increase from standing straight, indicates a restriction in lumbar movement and helps support the diagnosis of ankylosing spondylitis. Next, let's talk about investigations. The key investigations include inflammatory markers, for example CRP and ESR, which may rise with disease activity, HLA-B27 genetic testing, an X-ray of the spine and sacrum, and an MRI scan of the spine, which can show bone marrow edema early in the disease before there's any X-ray changes. So let's talk about the X-ray changes. A bamboo spine is the typical X-ray finding in the later stages of ankylosing spondylitis, where there's fusion of the sacroiliac and the spinal joints. X-rays in ankylosing spondylitis can also show squaring of the vertebral bodies, subchondral sclerosis and subchondral erosions, syndesmophytes, which are areas of bone growth where the ligaments insert into the bone, ossification of the ligaments, discs, and joints, which is where these structures start to turn into bone, and fusion of the facet, sacroiliac, and costovertebral joints. Finally, let's talk about management. The rheumatology multidisciplinary team will manage patients. Treatment aims to control the symptoms and preserve function. Medical management may involve non-steroidal anti-inflammatory drugs or NSAIDs, for example naproxen, which are first line. Anti-TNF medications are second line, for example adalimumab, etanercept, or infliximab. Third line are monoclonal antibodies against interleukin-17, for example secukinumab and ixekizumab. And another third-line option is upadacitinib, which is a JAK inhibitor. Intra-articular steroid injections may be considered for specific joints. Additional management involves physiotherapy, exercise and mobilization, avoiding smoking, bisphosphonates to treat osteoporosis, and surgery may occasionally be required for severe joint deformity. Chapter 99: Systemic Lupus Erythematosus. Systemic lupus erythematosus, or SLE, is an inflammatory autoimmune connective tissue disorder. It is systemic because it affects multiple systems and organs. Erythematosus refers to the typical red malar rash that can occur across the face. Systemic lupus erythematosus can affect anyone, but it occurs more commonly in women, Asian, African, Caribbean, and Hispanic ethnicity, and young to middle-aged adults. The condition typically takes a relapsing, remitting course, with flare-ups where the symptoms are worse and periods where the symptoms settle. The result of chronic inflammation means that systemic lupus erythematosus can shorten life expectancy, although this is mitigated with effective management. Cardiovascular disease and infection are significant complications. Let's talk briefly about the pathophysiology. Systemic lupus erythematosus is characterized by anti-nuclear antibodies. These are autoantibodies against proteins within the cell nucleus. These antibodies generate a chronic inflammatory response by the immune system, leading to the condition's features. Let's talk about the presentation. Systemic lupus erythematosus presents with many non-specific symptoms, such as fatigue, weight loss, arthralgia or joint pain, non-erosive arthritis, myalgia or muscle pain, fever, a photosensitive malar rash, which we'll talk in more detail about shortly, lymphadenopathy or abnormal enlarged lymph nodes, splenomegaly or an enlarged spleen, shortness of breath, pleuritic chest pain, which is sharp chest pain, particularly on inspiration or breathing in, mouth ulcers, hair loss, Raynaud's phenomenon, and edema or swelling, which is due to nephritis or inflammation in the kidneys. The typical malar rash is shaped like a butterfly across the nose and the cheeks, and it's triggered or worsened by sunlight. Next, let's go through the investigations. Abnormal investigation findings include autoantibodies, which we'll talk about in more detail shortly. A full blood count may show anemia of chronic disease, a low white blood cell count, and low platelets. A CRP and ESR may be raised with active inflammation. Complement component C3 and C4 levels may be decreased in active disease. Urinalysis and urine protein creatinine ratio shows proteinuria or protein in the urine in lupus nephritis, which is where there's inflammation in the kidneys due to the disease. And a renal biopsy may be used to investigate for lupus nephritis. Let's talk about the autoantibodies. Around 85% of patients who have systemic lupus erythematosus will be positive for anti-nuclear antibodies, or ANA. These can be positive in healthy individuals and those with other autoimmune conditions, for example, autoimmune hepatitis. A positive result needs to be interpreted in the context of their symptoms, so a positive ANA doesn't automatically mean systemic lupus erythematosus. Anti-double-stranded DNA antibodies are highly specific to systemic lupus erythematosus, meaning a positive result suggests SLE rather than other causes. Around half of patients with SLE will have anti-dsDNA or double-stranded DNA antibodies. The levels vary with disease activity, meaning they go up if the disease is more active and fall if the disease is well controlled, and this makes them helpful for monitoring the disease activity and the response to treatment. If you order an extractable nuclear antigen panel, this looks for antibodies against specific proteins in the cell nucleus, and it helps diagnose and distinguish between different connective tissue disorders. Anti-SM antibodies are highly specific to SLE, but not very sensitive. Anti-centromere antibodies are most associated with limited cutaneous systemic sclerosis. Anti-Rho and anti-LA antibodies are most associated with Sjogren's syndrome. Anti-SCL70 are most associated with systemic sclerosis, and anti-Jo1 antibodies are most associated with dermatomyositis. Antiphospholipid antibodies and antiphospholipid syndrome can occur secondary to systemic lupus erythematosus in up to 40% of patients with the condition. These antibodies, antiphospholipid antibodies, are associated with an increased risk of venous thromboembolism, for example, deep vein thrombosis or pulmonary embolism. Next, let's talk about the diagnostic criteria. The European League Against Rheumatism / American College of Rheumatology classification criteria from 2019 can be used for the diagnosis, and this takes into account the clinical features and the presence of antibodies. Next, let's talk about the complications. Cardiovascular disease is a leading cause of death. Chronic inflammation in the blood vessels leads to hypertension or high blood pressure and coronary artery disease, which can cause angina and myocardial infarction. Infection is more common in SLE, both due to the disease process and secondary to the immunosuppressant drugs. Anemia in SLE can be due to anemia of chronic disease, autoimmune hemolytic anemia, bone marrow suppression by medications, or due to kidney disease. This means a low hemoglobin could be multifactorial in patients with SLE. SLE can also cause leukopenia or low white cells, neutropenia or low neutrophils, and thrombocytopenia or low platelets. Pericarditis, or inflammation of the pericardial sac that surrounds the heart, causes sharp chest pain that gets worse on lying flat, and this is also a possible complication of SLE. Pleuritis, which is where SLE can cause inflammation of the lining of the lungs, causes sharp chest pain on inspiration or breathing in. Interstitial lung disease can be caused by inflammation in the lung tissue, and this leads to pulmonary fibrosis. Lupus nephritis, which is inflammation in the kidney caused by SLE, can progress to end-stage renal failure. Investigations include a urine protein creatinine ratio and a renal biopsy to diagnose lupus nephritis. The renal biopsy is often repeated to assess the response to treatment. Neuropsychiatric SLE is caused by inflammation in the central nervous system, and this can present with optic neuritis, or inflammation of the optic nerve, transverse myelitis, which is inflammation of the spinal cord, or psychosis. Recurrent miscarriage is more common in SLE, and in pregnancy there's also an increased risk of intrauterine growth restriction, preeclampsia, and preterm labor. And finally, venous thromboembolism may be associated with antiphospholipid syndrome occurring secondary to SLE. So let's talk about management. Treatment aims to control the symptoms and reduce complications with the least medications and the least side effects. Sun cream and sun avoidance are essential measures when managing the photosensitive malar rash. First-line options include hydroxychloroquine, non-steroidal anti-inflammatory drugs or NSAIDs, and steroids, for example prednisolone. Treatment options for resistant or more severe SLE include DMARDs, for example methotrexate, mycophenolate, and cyclophosphamide, and biologic therapies. Biologic therapy options include rituximab, which is a monoclonal antibody that targets the CD20 protein on the surface of B cells. Therefore, it reduces B cells and reduces the production of antibodies responsible for the disease. Or belimumab, which is a monoclonal antibody that targets B cell activating factor. Chapter 100. Discoid lupus erythematosus. Discoid lupus erythematosus, or DLE, is an autoimmune chronic skin condition. It's more common in women and typically presents between the ages of 20 and 50. It's more common in darker-skinned patients and smokers. Discoid lupus is associated with an increased risk of developing systemic lupus erythematosus. However, this risk is below 5%. meaning that patients with discoid lupus have less than a 5% risk of developing SLE. Rarely, the lesions can progress to squamous cell carcinoma of the skin, a type of skin cancer. Let's talk about the presentation. The lesions typically occur on the skin of the face, scalp, and ears. They are photosensitive, meaning that they're made worse or triggered by exposure to sunlight. They're associated with scarring alopecia, which is scarring and hair loss in the affected areas. And they're also associated with hyperpigmentation, which is increased pigmentation of the skin, or hypopigmentation, which is reduced pigmentation of the skin. The appearance of the lesions or plaques are inflamed, dry, erythematosus or red, and scaling. Finally, let's talk about management. A skin biopsy can be used to confirm the diagnosis, and treatment is with sun protection, topical steroids, intralesional steroid injections, where a steroid is injected into the skin lesion, and hydroxychloroquine. Chapter 101: Systemic Sclerosis. Systemic sclerosis is an autoimmune connective tissue disease involving inflammation and fibrosis, which is hardening or scarring of the connective tissues, the skin, and the internal organs. The cause is unclear. The term scleroderma translates directly to hardening of the skin. The terms systemic sclerosis and scleroderma are often used interchangeably. Most patients with scleroderma have systemic sclerosis. However, there is a localized version of scleroderma that only affects the skin. There are two main disease patterns in systemic sclerosis: limited cutaneous systemic sclerosis and diffuse cutaneous systemic sclerosis. So let's start with limited cutaneous systemic sclerosis. Limited cutaneous systemic sclerosis is the more limited version of the disease. It used to be called CREST syndrome, and CREST forms a mnemonic for remembering the features of limited cutaneous systemic sclerosis. C for calcinosis, R for Raynaud's phenomenon, E for esophageal dysmotility, S for sclerodactyly, and T for telangiectasia. And we'll talk in more detail about all of these features shortly. Next, let's discuss diffuse cutaneous systemic sclerosis. Diffuse cutaneous systemic sclerosis includes the CREST features, but it also affects the internal organs, causing cardiovascular problems, for example, hypertension and coronary artery disease, lung problems, for example, pulmonary hypertension and pulmonary fibrosis, and kidney problems, for example, glomerulonephritis and scleroderma renal crisis. So let's talk in more detail about the features. Scleroderma refers to hardening of the skin, giving the appearance of shiny, tight skin without the normal skin folds. These changes are most notable on the hands and the face. Sclerodactyly refers to the skin changes in the hands. Skin tightening around the joints of the hands restricts the range of motion and reduces the function. The fat pads on the fingers are lost, and the skin can break easily and ulcerate. Telangiectasia refers to dilated blood vessels in the skin measuring less than 1 mm in diameter. Calcinosis refers to calcium deposits under the skin, most commonly found on the fingertips. Esophageal dysmotility is caused by atrophy and dysfunction of the smooth muscle of the esophagus, as well as fibrosis of the esophagus. It causes swallowing difficulties, chest pain, acid reflux, and esophagitis, or inflammation in the esophagus. Systemic hypertension and pulmonary hypertension, or high blood pressure, is caused by connective tissue dysfunction in the systemic and the pulmonary arterial systems in the blood vessels. Systemic hypertension can be worsened by renal impairment. Pulmonary fibrosis occurs in severe systemic sclerosis, and this has a gradual onset of a dry cough and shortness of breath. Scleroderma renal crisis is a medical emergency with severe hypertension and renal failure. Next, let's talk about Raynaud's phenomena. Raynaud's phenomenon is where the fingertips change color in response to even mildly cold triggers, for example, opening the fridge. It's caused by vasoconstriction, or closing up of the vessels that supply the fingers. The typical pattern is they first turn white due to vasoconstriction, then they turn blue due to cyanosis, and then they turn red due to reperfusion and hyperemia. They go white because the blood vessels close, they go blue because of a lack of oxygen, and then when they reperfuse, they go red because blood rushes back into them. Raynaud's disease is where Raynaud's phenomenon occurs without associated systemic disease. It is idiopathic, meaning there's no other secondary cause, and it makes up 80 to 90% of patients who have Raynaud's phenomenon. Systemic sclerosis is the most important secondary cause of Raynaud's phenomenon. It's less commonly associated with systemic lupus erythematosus. Nail fold capillaroscopy is a technique to magnify and examine the peripheral capillaries where the skin meets the base of the fingernail, which is the nail fold. The signs that are suggestive of systemic sclerosis on nail fold capillaroscopy are abnormal capillaries, avascular areas where there's no blood vessels, and microhemorrhages, or small spots of bleeding. Patients with Raynaud's disease, where there's no systemic sclerosis, will have normal nail fold capillaries on capillaroscopy. The treatment options for Raynaud's includes keeping the hands warm, for example with gloves and hand warmers, calcium channel blockers, for example nifedipine, and other specialist drugs including losartan, ACE inhibitors, sildenafil, and fluoxetine. Beta blockers can worsen the symptoms of Raynaud's. Next, let's talk about autoantibodies in systemic sclerosis. Anti-nuclear antibodies, or ANA, are positive in most patients with systemic sclerosis. Anti-nuclear antibodies are non-specific, meaning they can occur in other diseases, for example SLE, or systemic lupus erythematosus, or autoimmune hepatitis. Anti-centromere antibodies are most associated with limited cutaneous systemic sclerosis. Anti-SCL70 antibodies are most associated with diffuse cutaneous systemic sclerosis and more severe disease. Next, let's talk about the diagnosis. The American College of Rheumatology / European League Against Rheumatism classification criteria from 2013 can be used to make the diagnosis, and this takes into account the clinical features, antibodies, and nail fold capillaroscopy. Next, let's talk about management. Disease-modifying anti-rheumatic drugs, or DMARDs, for example methotrexate, and biologic therapies, for example rituximab, are options in diffuse disease. Steroids may be considered but are associated with an increased risk of scleroderma renal crisis. Non-medical management involves avoiding smoking, gentle skin stretching to maintain the range of motion, regular emollients to keep the skin hydrated and healthy, avoiding cold triggers for Raynaud's, physiotherapy to help maintain healthy joints, and occupational therapy for adaptations to daily living to cope with the limitations. Medical management focuses on treating the symptoms and the complications. Nifedipine is usually first line for Raynaud's phenomenon. Proton pump inhibitors, for example omeprazole or lansoprazole, are used to treat acid reflux. Prokinetic medications, for example metoclopramide, can be used for gastrointestinal symptoms. Analgesia can be used for joint pain. Antibiotics may be required for skin infections. Antihypertensive medication, for example ACE inhibitors, are used to treat hypertension and scleroderma renal crisis. Endothelin receptor antagonists, for example bosentan, may be used for pulmonary hypertension and digital ulcers, or ulcers on the fingers. Sildenafil may be used for pulmonary hypertension and digital ulcers associated with Raynaud's phenomenon. Intravenous iloprost may be used for digital ulcers. Oxygen may be required for pulmonary fibrosis, and a stem cell transplantation may be considered in rapidly progressing severe disease, but this carries significant risks. Chapter 102. Polymyalgia rheumatica. Polymyalgia rheumatica, or PMR, is an inflammatory condition that causes pain and stiffness in the shoulders, pelvic girdle, and neck. There's a strong association with giant cell arteritis, and the two conditions often occur together. The cause of PMR is not fully understood. There are no relevant antibodies. It is more common in older, white patients. Let's talk about the presentation. Patients may have a relatively rapid onset of symptoms, for example over days or weeks. Symptoms should be present for 2 weeks before a diagnosis is considered. The core symptoms are pain and stiffness of the shoulders, potentially radiating to the upper arm and the elbow, pelvic girdle around the hips, potentially radiating to the thighs, and the neck. The characteristic features of the pain and stiffness are that it's worse in the morning, worse after rest or inactivity, interferes with sleep, takes at least 45 minutes to ease in the morning, and somewhat improves with activity. Associated features can include systemic symptoms, for example weight loss, fatigue, and a low-grade fever, muscle tenderness, carpal tunnel syndrome, and peripheral edema. Let's go through the differential diagnosis. The presenting symptoms are not specific to polymyalgia rheumatica, and there's a long list of differentials, including osteoarthritis, rheumatoid arthritis, systemic lupus erythematosus, statin-induced myopathy, myositis, for example polymyositis, cervical spondylosis, which is wear and tear in the spine and the neck, adhesive capsulitis or frozen shoulder, hyperthyroidism or hypothyroidism, osteomalacia, fibromyalgia, lymphoma or leukemia, and myeloma. Let's talk about making the diagnosis. The diagnosis is based on the clinical presentation, the response to treatment with steroids, and excluding the differentials. Inflammatory markers, for example ESR and CRP, are usually raised, but they may be normal. The NICE Clinical Knowledge Summaries updated in January 2023 advise investigations before initiating steroids. And these investigations will include a full blood count, a renal profile or Usinese, liver function tests, calcium, which could be abnormal in hyperparathyroidism, cancer, and osteomalacia, serum protein electrophoresis, which will look for myeloma, thyroid-stimulating hormone to check the thyroid function, creatine kinase, which looks for myositis, rheumatoid factor to look for rheumatoid arthritis, and a urine dipstick test. Additional investigations to consider include anti-nuclear antibodies for systemic lupus erythematosus, anti-cyclic citrullinated peptide or anti-CCP antibodies for rheumatoid arthritis, a urine Bence-Jones protein for myeloma, and a chest X-ray for lung and mediastinal abnormalities, for example, lung cancer or lymphoma. Next, let's talk about treatment. Treatment of polymyalgia rheumatica is with steroids. The NICE clinical knowledge summaries updated in January 2023 recommend 15 milligrams of prednisolone daily initially and follow up after 1 week. Patients with PMR have a dramatic improvement in symptoms of at least 70% within 1 week of taking steroids. Inflammatory markers will return to normal within 1 month. A poor response to steroids suggests an alternative diagnosis. Treatment with steroids typically lasts 1 to 2 years. NICE suggest following a reducing regime of prednisolone, for example 15 milligrams until the symptoms are fully controlled, then 12.5 milligrams for 3 weeks, then 10 milligrams for 4 to 6 weeks, then reducing by 1 milligram every 4 to 8 weeks thereafter. The reducing regime can go faster or slower depending on the individual and their symptom control. Steroid-related complications include weight gain, diabetes, bruising of the skin, osteoporosis, high blood pressure, and cataracts. Additional management for patients on long-term steroids can be remembered with the "don't stop" mnemonic. Don't refers to steroid dependence, which occurs after 3 weeks of treatment, and abruptly stopping the steroids risks adrenal crisis. As the patient takes steroids for a long time, their own production of steroids shuts down, which means they're at risk of adrenal crisis if they stop taking the steroids. S stands for sick day rules, and this refers to the fact the steroid doses may need to increase if the patient becomes unwell. Normally when you're unwell, your natural production of steroids increases. Patients on long-term steroids don't have as much natural production of steroids, so their doses may need to increase to compensate. T is for treatment card, and patients should carry a steroid treatment card that alerts others that they're steroid dependent. O is for osteoporosis prevention, which may be required, for example, bisphosphonates and calcium and vitamin D. And P is for proton pump inhibitors, which should be considered for gastroprotection, for example, omeprazole. Chapter 103: Giant Cell Arteritis. Giant cell arteritis, or GCA, is also known as temporal arteritis. It's a type of systemic vasculitis affecting the medium and large arteries. There's a strong link between giant cell arteritis and polymyalgia rheumatica. It's more common in older, white patients. The key complication of giant cell arteritis is vision loss, which is often irreversible. Therefore, it needs prompt recognition and management. So let's talk about the presentation. A unilateral headache is the primary presenting feature. Typically, this is severe and located around the temple and the forehead. It may be associated with scalp tenderness, for example, noticed when brushing the hair, jaw claudication, which is aching in the jaw when chewing, blurring or double vision, and loss of vision if untreated. The temporal artery may be tender and thickened on palpation, and when palpating, the pulse may be reduced or absent. Associated features include symptoms of polymyalgia rheumatica, for example, shoulder and pelvic girdle pain and stiffness, systemic symptoms, for example, weight loss, fatigue, and a low-grade fever, muscle tenderness, carpal tunnel syndrome, and peripheral edema. Let's talk about making the diagnosis. The diagnosis is based on the clinical presentation, raised inflammatory markers, particularly ESR or erythrocyte sedimentation rate, which is usually more than 50 millimeters per hour, a temporal artery biopsy, which shows multinucleated giant cells, and duplex ultrasound of the temporal artery can show the hypoechoic halo sign and stenosis of the artery. Next, let's talk about management. Steroids are the mainstay of treatment. They should be started immediately before confirming the diagnosis to reduce the risk of vision loss. There is usually a rapid and significant response to steroid treatment. The dose and choice of steroids depend on whether there's visual symptoms or jaw claudication. For example, 40 to 60 milligrams of oral prednisolone daily if the patient has no visual symptoms and no jaw claudication. But if they do have visual symptoms or jaw claudication, they may be treated with 500 milligrams to 1,000 milligrams of intravenous methylprednisolone daily. Once the diagnosis is confirmed and the condition is controlled, the steroid dose is slowly weaned over 1 to 2 years. Other medications that are considered include aspirin, 75 milligrams daily, to decrease the risk of vision loss and strokes. Proton pump inhibitors, for example, omeprazole for gastroprotection whilst the patient's taking steroids, and bisphosphonates and calcium and vitamin D supplementation for bone protection whilst on steroids. A combination of specialists should manage patients with giant cell arteritis, including rheumatologists for specialist diagnosis and management, vascular surgeons for a temporal artery biopsy, and ophthalmology review for visual symptoms. Finally, let's go through the complications. The key complications are steroid-related complications, for example, weight gain, diabetes, and osteoporosis, vision loss, and cerebrovascular accident, or stroke. Chapter 104, Myositis. Polymyositis and dermatomyositis are autoimmune conditions that cause muscle inflammation, which is called myositis. Both conditions present with proximal muscle weakness at the tops of the arms and the tops of the legs. Dermatomyositis also involves characteristic skin changes, specifically Gottron papules affecting the backs of the hands and the heliotrope rash affecting the eyelids. Polymyositis and dermatomyositis can be caused by an underlying cancer, which makes them paraneoplastic syndromes. A viral infection may be the trigger, for example, Coxsackie virus or HIV. Certain HLA genes are risk factors for the conditions. Let's talk about the presentation. The typical presenting symptom is a gradual onset, symmetrical, proximal muscle weakness, which causes difficulties in standing from a chair, climbing stairs, or lifting items overhead. There may be muscle pain or myalgia, but this is not always the case. Polymyositis occurs without any skin changes. Potential skin changes in dermatomyositis include Gottron lesions, which are scaly erythematous patches over the knuckles, elbows, and knees. The heliotrope rash, which is a purple rash on the face and eyelids. Periorbital edema, which is swelling around the eyes, and a photosensitive erythematous rash or red rash over the back, shoulders, and neck. Next, let's talk about creatine kinase. The critical test for myositis or muscle inflammation is a creatine kinase blood test. Creatine kinase is an enzyme found inside muscle cells. Inflammation inside muscle cells, or myositis, causes the release of creatine kinase. Creatine kinase is usually less than about 300 international units per litre. With myositis, the result can be in the multiples of thousands. Other causes of a raised creatine kinase include rhabdomyolysis, acute kidney injury, myocardial infarction or a heart attack, statin use, and strenuous exercise. Next, let's talk about making the diagnosis. A diagnosis will be made by a rheumatology specialist, and this is based on the clinical features, elevated creatine kinase blood test, autoantibodies, electromyography or EMG, magnetic resonance imaging or MRI scans, and a muscle biopsy. There are many myositis-specific antibodies with varying associations. The most common one to remember is anti-Jo1 antibodies associated with polymyositis. Finally, let's talk about management. A rheumatologist will guide management. New cases need to be assessed for possible underlying cancer. Patients may benefit from physiotherapy and occupational therapy to help with muscle strength and function. Corticosteroids, for example prednisolone, are the first-line treatment for both polymyositis and dermatomyositis. Other medical options where the response to steroids is inadequate include immunosuppressants, for example methotrexate or azathioprine, IV immunoglobulins, and biologic therapy, for example infliximab or etanercept. Chapter 105: Antiphospholipid Syndrome. Antiphospholipid syndrome is an autoimmune disorder caused by antiphospholipid antibodies. These antibodies target the proteins that bind to phospholipids on the cell surface, causing inflammation and increasing the risk of thrombosis or blood clots. Antiphospholipid syndrome can occur in isolation, or it may be associated with another autoimmune condition, particularly systemic lupus erythematosus. Let's talk about the antibodies. The specific antiphospholipid antibodies are lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. Usually when you're requesting antibodies from the lab, you can simply tick a box that says antiphospholipid antibodies. Let's talk about the complications. The key complications of antiphospholipid syndrome are venous thromboembolism, for example deep vein thrombosis and pulmonary embolism, arterial thrombosis, for example stroke, myocardial infarction, and renal thrombosis, and pregnancy-related complications, for example recurrent miscarriage, stillbirth, and preeclampsia. Catastrophic antiphospholipid syndrome is a rare complication with rapid thrombosis in multiple organs within a few days, and this has a high mortality rate. A Tom tip for you: in your exams, look out for the patient with thrombosis, for example deep vein thrombosis or stroke, and a history of recurrent miscarriage. The diagnosis in this case is likely to be antiphospholipid syndrome. Next, let's talk about the associations. Livedo reticularis is a purple, lace-like, which is what reticular refers to, rash that gives a mottled appearance to the skin. A more permanent version of this rash, called livedo racemosa, is associated with antiphospholipid syndrome. Lieberman-Sachs endocarditis is a non-bacterial endocarditis which has growths or vegetations on the heart valves, most often the mitral and the aortic valves. Lieberman-Sachs endocarditis is associated with systemic lupus erythematosus and antiphospholipid syndrome. Thrombocytopenia, or a low platelet count, is a common finding in antiphospholipid syndrome. Finally, let's talk about management. The diagnosis is based on clinical features and the presence of antiphospholipid antibodies. Long-term warfarin with a target INR of 2 to 3 is used to prevent thrombosis. Low molecular weight heparin, for example enoxaparin, and aspirin are used in pregnancy to reduce the risks. Warfarin is contraindicated in pregnancy. A Tom tip for you: in many situations, DOACs have replaced warfarin as the anticoagulant of choice. The situations where this is not the case and DOACs are not used are metallic heart valves and antiphospholipid syndrome. Chapter 106 Sjogren Syndrome. Sjogren syndrome is an autoimmune condition that affects the exocrine glands, notably the lacrimal glands and the salivary glands, and it causes symptoms of a dry mouth and dry eyes. It can also cause vaginal dryness. Dry eyes and a dry mouth can be called Sicca symptoms. It can also cause dry skin, joint pain, and stiffness. Sjogren syndrome is more common in women and typically presents in middle age. Primary Sjogren's is where the condition occurs on its own. Secondary Sjogren's is where it occurs due to other conditions, such as systemic lupus erythematosus and rheumatoid arthritis. Antibodies associated with Sjogren's are anti-SSA antibodies, also called anti-Ro antibodies, and anti-SSB antibodies, also called anti-LA antibodies. Let's talk about the Schirmer test. The Schirmer test involves inserting folded filter paper under the lower eyelid with the end hanging out. Moisture from the eye will travel by diffusion along the filter paper. After 5 minutes, the distance that the moisture from the eye travels along the filter paper is measured. In a healthy young adult, 15 millimeters is expected. Less than 10 millimeters is significant and suggests Sjogren syndrome. Next, let's talk about management. The diagnosis is typically made based on the clinical features and the presence of antibodies. A salivary gland biopsy may be used to confirm the diagnosis, but it's not usually necessary. Management involves rheumatology and ophthalmology. Treatment options include artificial tears, for example, polyvinyl alcohol eye drops during the day and Carbomer gel at nighttime, artificial saliva, vaginal lubricants if necessary. Oral pilocarpine can be used to stimulate tear and saliva production, and hydroxychloroquine may be considered, mainly in patients with associated joint pain. The mechanism of action of pilocarpine is to stimulate muscarinic receptors, stimulating the parasympathetic nerves and promoting salivary and lacrimal gland secretion. Finally, let's talk about the complications. Complications related to exocrine gland dysfunction include eye problems such as keratoconjunctivitis sicca and corneal ulcers, oral problems such as dental cavities and candida infections, and vaginal problems such as candida infection and sexual dysfunction. Sjogren's can rarely affect other organs, causing complications such as pneumonia, bronchiectasis, non-Hodgkin's lymphoma, peripheral neuropathy, vasculitis, and renal impairment. Chapter 107 Vasculitis. Vasculitis describes inflammation of the blood vessels. Various specific diseases cause vasculitis, and these can be categorized based on whether they affect the small, medium, or large vessels. Let's start with a summary of the different types of vasculitis. Henoch-Schönlein purpura affects the small vessels, and the key features are purpura, which is a non-blanching rash, and IgA nephritis. Microscopic polyangiitis affects the small vessels. It's associated with P-ANCA antibodies, and the key features are glomerular nephritis in the kidneys and diffuse alveolar hemorrhage in the lungs. Granulomatosis with polyangiitis affects the small vessels. It's associated with C-ANCA antibodies, and the key features are nasal symptoms, respiratory symptoms, and glomerular nephritis in the kidneys. Eosinophilic granulomatosis with polyangiitis affects the small vessels. It's associated with P-ANCA antibodies and raised eosinophils, and the key features are late onset asthma and sinusitis and rhinitis in the nose. Polyarteritis nodosa affects the medium-sized vessels, and the key features are renal impairment, hypertension or high blood pressure, cardiovascular events, and tender skin nodules. Kawasaki disease affects the medium-sized vessels, and the key features are a high fever for more than 5 days, a widespread rash, bilateral conjunctivitis, a strawberry tongue, and coronary artery aneurysms. Giant cell arteritis affects the large vessels. The lab finding is a raised ESR or erythrocyte sedimentation rate, and the key features are unilateral headache, scalp tenderness, and vision loss. And finally, Takayasu's arteritis affects the large vessels, and the key features are that the aortic arch is affected, and it's called pulseless disease. And we'll go through all of these in more detail shortly. Let's go through the generic presentation. There are generic vasculitis features and features more specific to individual types of vasculitis. The generic features include joint and muscle pain, peripheral neuropathy, renal impairment, purpura, which are purple-colored non-blanching spots that are caused by blood leaking from the vessels under the skin, necrotic skin ulcers, and gastrointestinal symptoms, for example, diarrhea, abdominal pain, and bleeding. Patients with vasculitis may also have associated systemic symptoms, including fatigue, fever, night sweats, weight loss, anorexia or loss of appetite, and anemia. Let's talk about the investigations. Inflammatory markers, for example CRP and ESR, are usually raised with vasculitis, as it's an inflammatory condition. Anti-neutrophil cytoplasmic antibodies, or ANCA, are associated with specific types of vasculitis. P-ANCA, or MPO antibodies, are associated with microscopic polyangiitis and eosinophilic granulomatosis with polyangiitis. And C-ANCA, or PR3 antibodies, are associated with granulomatosis with polyangiitis. A Tom tip for you: the 3 types of vasculitis with polyangiitis in the name are associated with anti-neutrophil cytoplasmic antibodies, or ANCA. If you simply remember this fact, you'll be doing pretty well. Poly refers to multiple, angi refers to blood vessels, and itis refers to inflammation. Microscopic polyangiitis, granulomatosis with polyangiitis, and eosinophilic granulomatosis with polyangiitis are types of small vessel vasculitis, and they can all affect the lungs and the kidneys. Next, let's talk about management. The management of vasculitis depends on the type, and it's guided by a specialist rheumatologist. Treatment usually involves steroids and immunosuppressants. Steroids may be administered to target the affected area. Systemic steroids, for example oral steroids like prednisolone or intravenous steroids like hydrocortisone, can be used for systemic symptoms. Nasal steroids may be used for nasal symptoms, for example in granulomatosis with polyangiitis, and inhaled steroids can be used for lung involvement, for example with eosinophilic granulomatosis with polyangiitis. Let's talk about Henoch-Schönlein purpura. Henoch-Schönlein purpura, or HSP, is an IgA or immunoglobulin A vasculitis that presents in children with a purpuric rash that affects the lower limbs and the buttocks. Inflammation occurs due to immunoglobulin A deposits in the blood vessels. HSP affects the skin, kidneys, and the gastrointestinal tract. It may be triggered by an upper airway infection or by gastroenteritis. It's most common in children under the age of 10 years. The 4 classic features are purpura, which occur in 100% of patients, joint pain, which occur in typically 75% of patients, abdominal pain in 50%, and renal involvement with an IgA nephritis in about 50%. Management of HSP is primarily supportive with analgesia, rest, and good hydration. The use of steroids is debatable. Patients are closely monitored with repeated urine dipstick testing to monitor for renal involvement and blood pressure monitoring to look for hypertension. Patients without kidney involvement typically recover within 4 to 6 weeks. A third of patients have a recurrence of the disease within 6 months, and a tiny proportion develop end-stage renal failure. Next, let's talk about microscopic polyangiitis. Microscopic polyangiitis is a small vessel vasculitis. The main feature is renal failure caused by glomerulonephritis. It can affect the lungs with diffuse alveolar hemorrhage, which causes hemoptysis, where the patient coughs up blood. Next, let's talk about granulomatosis with polyangiitis. Granulomatosis with polyangiitis was previously called Wegener's granulomatosis, and it's a small vessel vasculitis that primarily affects the respiratory tract and the kidneys. In the upper respiratory tract, it commonly affects the nose, causing nosebleeds or epistaxis, crusting in the nose and nasal secretions. In the ears, it causes hearing loss, and in the sinuses, it causes sinusitis. A classic sign of granulomatosis with polyangiitis is a saddle-shaped nose due to nasal bridge collapse, causing the nasal ridge to dip inwards. So the middle of the nose dips inwards, forming a saddle shape. In the lower respiratory tract, it can cause a cough, wheeze, and hemoptysis, or blood. In the kidneys, it can cause a rapidly progressing glomerulonephritis. Next, let's talk about eosinophilic granulomatosis with polyangiitis. Eosinophilic granulomatosis with polyangiitis was previously called Churg-Strauss syndrome, and it's a small vessel vasculitis that primarily affects the lungs and the skin, but it can affect the other organs such as the kidneys. It typically presents with severe asthma in middle age, but it can present as early as the teenage years. There may also be sinusitis and allergic rhinitis. Raised eosinophils on the full blood count is the characteristic finding. Next, let's talk about polyarteritis nodosa. Polyarteritis nodosa is a medium vessel vasculitis. It can be idiopathic, meaning no clear cause, or secondary to infections, particularly hepatitis B. Typical features include renal impairment, hypertension, tender erythematous skin nodules, myocardial infarction, stroke, and mesenteric arteritis, causing gastrointestinal symptoms. Next, let's talk about Kawasaki disease. Kawasaki disease is a medium vessel vasculitis. Kawasaki disease affects young children, typically under the age of 5. There is no clear cause. The clinical features include a persistent high fever for more than 5 days, and this is the typical sign that you'll see in your exams that should make you think about Kawasaki disease. A widespread erythematous maculopapular rash, desquamation or skin peeling of the palms and the soles, bilateral conjunctivitis affecting the eyes, and a strawberry tongue, which is a red tongue with prominent papillae, making the tongue look like a strawberry. A key complication of Kawasaki disease is coronary artery aneurysms. Treatment is with aspirin and IV immunoglobulins. Finally, let's talk about Takayasu's arteritis. Takayasu's arteritis is a form of large vessel vasculitis. It mainly affects the aorta and the aortic branches. It can also affect the pulmonary arteries. These vessels can swell and form aneurysms or become narrow and blocked. Stenosis or occlusion of these vessels can reduce the pulses and the blood pressure in a limb, leading to the name of pulseless disease. Takayasu's arteritis usually presents before aged 40 with non-specific systemic symptoms such as fever, malaise, and muscle aches. There may be claudication symptoms, meaning pain and fatigue that worsen whilst using the affected limb, particularly in an arm. Diagnosis involves CT or MRI angiography. Chapter 108. Behçet's disease. Behçet's disease is a complex inflammatory condition affecting the blood vessels and the tissues. The main features are recurrent oral and genital ulcers. It can affect other areas such as the eyes, skin, gastrointestinal tract, lungs, blood vessels, musculoskeletal system, and central nervous system. Symptoms can range from mild to severe. There's a link with the HLA-B51 gene. Let's start with the differential diagnosis of the most commonly presenting feature, which is mouth ulcers. Mouth ulcers are very common and have a long list of possible causes. Simple aphthous ulcers are very common without any associated disease. Other differentials are squamous cell carcinoma, herpes simplex virus, hand, foot, and mouth disease caused by Coxsackie A virus, inflammatory bowel disease, for example, Crohn's disease, celiac disease, connective tissue diseases, for example, rheumatoid arthritis and systemic lupus erythematosus, vitamin deficiency, for example, deficiency in iron, B12, folate, or vitamin D, and HIV. Let's talk in more detail about the features of Behçet's disease. Oral ulcers are expected at least 3 times per year in patients with the disease. They are painful, sharply circumscribed erosions with a red halo on the oral mucosa inside the mouth. They heal over 2 to 4 weeks. Genital ulcers are similar in appearance to the oral ulcers. The ulcers may leave a scar. Behçet's disease can affect many organs in the body, including the skin with erythema nodosum and papules and pustules similar to acne, the eyes with anterior or posterior uveitis, retinal vasculitis, and retinal artery or retinal vein thrombosis. The musculoskeletal system, for example with stiffness, arthralgia or aching in the joints, and oligoarthritis. Gastrointestinal symptoms, for example ulceration in the ileum, cecum, and ascending colon. The central nervous system causing aseptic meningitis and cerebral venous sinus thrombosis. The arteries, for example causing aneurysms, and the veins, for example causing deep vein thrombosis and Budd-Chiari syndrome. So there's a huge number of features that we've gone through there, but the most important ones to remember for your exams are oral ulcers and genital ulcers. Let's talk about the pathogy test. The pathogy test involves using a sterile needle to make multiple pricks on the forearm. The area is reviewed 24 to 48 hours later to look for erythema or redness and induration or thickening, which can indicate non-specific skin hypersensitivity. A positive result in the pathogy test can indicate Behçet's disease, Sweets syndrome, or pyoderma gangrenosum. Next, let's talk about management. Behçet's disease is a clinical diagnosis based on the signs and symptoms. A specialist rheumatologist will coordinate management. Other specialties may be involved depending on the affected areas, such as dermatology, ophthalmology, and neurology. Management involves a combination of topical steroids for mouth ulcers, for example, soluble betamethasone tablets, systemic steroids, for example, oral prednisolone, colchicine can help with the symptoms, topical anesthetics for genital ulcers, for example, lidocaine ointment, immunosuppressants, for example, azathioprine, and biologic therapy, for example, infliximab. Finally, let's talk about the prognosis. Behçet's disease takes a relapsing remitting course. Patients may go into complete remission. Most patients have a normal life expectancy. Major complications include vision loss, ruptured pulmonary aneurysms, bowel perforation, and neuro-Behçet's disease. Chapter 109. Ehlers-Danlos Syndrome. Ehlers-Danlos syndrome, or EDS, is a group of genetic conditions involving defects in collagen, causing hypermobility in the joints and abnormalities in the connective tissue of the skin, bones, blood vessels, and organs. A tom tip for you, Marfan syndrome is a key differential diagnosis for hypermobility. Key features of Marfan syndrome are a high-arched palate, arachnodactyly or long fingers, and an increased arm span to body height ratio. Let's start by going through the types. Hypermobile Ehlers-Danlos syndrome is the most common and least severe type of Ehlers-Danlos syndrome, although it still causes significant disability and psychosocial issues. Features include joint hypermobility and soft and stretchy skin. A single gene for hypermobile Ehlers-Danlos syndrome has not been identified. It appears to be inherited in an autosomal dominant pattern. Classical Ehlers-Danlos syndrome features remarkably stretchy skin that feels smooth and velvety. There is severe joint hypermobility, joint pain, and abnormal wound healing. Lumps often develop over pressure points such as the elbows. Patients are prone to hernias, prolapses, mitral regurgitation, and aortic root dilatation. Inheritance of classical Ehlers-Danlos syndrome is autosomal dominant. Vascular Ehlers-Danlos syndrome is the most severe and dangerous form of the condition, where the blood vessels are particularly fragile and prone to rupture. Patients have characteristic thin, translucent skin. Other features include gastrointestinal perforation and spontaneous pneumothorax. Patients with vascular Ehlers-Danlos syndrome are monitored for vascular abnormalities and told to seek urgent medical attention for sudden, unexplained pain or bleeding. Inheritance is autosomal dominant. Finally, kyphoscoliotic Ehlers-Danlos syndrome is characterized initially by poor muscle tone or hypotonia as a neonate and infant, followed by kyphoscoliosis as they grow. There is significant joint hypermobility, joint dislocation is common, and inheritance is autosomal recessive. A tom tip for you, hypermobile Ehlers-Danlos syndrome is the most common. Remember the extremely stretchy skin and severe joint hypermobility associated with classical Ehlers-Danlos syndrome, and the thin, translucent skin and blood vessel rupture associated with vascular Ehlers-Danlos syndrome. Let's talk about the presentation. The most common presenting feature of hypermobile Ehlers-Danlos syndrome is joint pain and hypermobility. However, it is a multi-system disorder and symptoms occur across multiple areas of the body. Features include joint dislocations, for example, of the shoulders or hips, soft and stretchy skin, stretch marks or striae, easy bruising, poor wound healing, excessive bleeding, chronic pain which can be widespread, chronic fatigue, headaches, autonomic dysfunction, for example, POTS, which we'll talk about shortly, gastroesophageal reflux, abdominal pain, irritable bowel syndrome, menorrhagia or heavy periods, and dysmenorrhea or painful periods, premature rupture of membranes in pregnancy, urinary incontinence, pelvic organ prolapse, and temporomandibular joint dysfunction. Postural orthostatic tachycardia syndrome, or POTS, can occur with hypermobile Ehlers-Danlos syndrome as a result of autonomic dysfunction. Significant tachycardia, or a fast heart rate, occurs on sitting or standing, and the symptoms include presyncope or lightheadedness, syncope, which is loss of consciousness, headaches, disorientation, nausea, and tremor, which typically occur on sitting up or standing. Next, let's talk about the Baton score. The Baton score is used to assess for hypermobility and support the diagnosis. 1 point is scored for each side of the body, with a maximum score of 9. Points are given if the patient can place their palms flat on the floor with their legs straight, which scores 1, hyperextend their elbows, hyperextend their knees, bend their thumb to touch the forearm, and hyperextend the little finger backwards past 90 degrees. A Tom tip is worth learning and remembering to use the Baton score to assess patients for hypermobility. Finally, let's talk about management. Hypermobile Ehlers-Danlos syndrome is a clinical diagnosis assisted by the Baton score. Genetic testing is helpful in the other subtypes of Ehlers-Danlos syndrome. There is no cure for Ehlers-Danlos syndrome. Management focuses on maintaining healthy joints, managing symptoms, supporting daily activities, and monitoring for complications. This will involve follow-up with relevant specialists depending on the associated complications, physiotherapy to strengthen and stabilize the joints and maintain good posture, occupational therapy to maximize function, moderating activity to minimize flare-ups of pain, and psychology input may be required to support well-being. Hypermobility in the joints leads to additional wear and tear, resulting in premature osteoarthritis. Chapter 110. Gout. Gout is a crystal arthropathy associated with chronically high uric acid levels in the blood. Urate crystals are deposited in the joint, causing it to become inflamed. Gout typically presents with a single, acute, hot, swollen, and painful joint. The critical differential diagnosis for this presentation is septic arthritis with infection in the joint. Gouty tophi are subcutaneous uric acid deposits typically seen on the hands, elbows, and ears under the skin. Let's go through the risk factors. The risk factors for gout are being male, family history, obesity, a high purine diet, for example with lots of meat and seafood, alcohol, diuretic use, cardiovascular disease, and kidney disease. Let's talk about the typical joints. The most commonly affected joints are the base of the big toe, which is the metatarsophalangeal joint or MTP joint, the base of the thumb, which is the carpometacarpal joint or the CMC joint, and the wrist. Gout can also affect the larger joints, for example the knee or ankle. Next, let's talk about making the diagnosis. The diagnosis is usually made clinically, supported by a raised serum urate level on the blood test. It's essential to exclude septic arthritis, which is a potentially life-threatening differential diagnosis. Any suspicion of septic arthritis requires emergency management with joint aspiration and antibiotics. Aspirated joint fluid shows monosodium urate crystals in gout. These are needle-shaped and negatively birefringent of polarized light. There should be no bacterial growth. A Tom tip for you, the monosodium urate crystals of gout are needle-shaped and negatively birefringent of polarized light. The calcium pyrophosphate crystals of pseudogout are rhomboid-shaped and positively birefringent. These key facts help you differentiate them in exams. X-ray of a joint affected by gout shows maintained joint space or no loss of joint space, lytic lesions in the bone, punched out erosions, and the erosions can have sclerotic borders with overhanging edges. Next, let's talk about management. Acute flare-ups of gout are treated with non-steroidal anti-inflammatory drugs or NSAIDs, for example naproxen, first line, and these are typically co-prescribed with a proton pump inhibitor such as omeprazole for gastroprotection to protect the stomach. Colchicine is second line, and oral steroids, for example prednisolone, are third line. Colchicine is used in patients who are inappropriate for non-steroidal anti-inflammatory drugs, such as patients with renal impairment or significant heart disease. Abdominal symptoms and diarrhea are common side effects of colchicine. These may be mild and resolve with a reduced dose. However, more severe symptoms may indicate toxicity, and colchicine is very dangerous in overdose and can cause multiple organ failure. Colchicine is only prescribed for a short course, for example up to 6 mg per course. Prophylaxis against gout is with xanthine oxidase inhibitors which lower the uric acid level. The options are allopurinol or febuxostat. Lifestyle changes can reduce the risk of gout, including losing weight, staying hydrated, reducing the alcohol intake, and minimizing purine-based food in the diet, for example meat and seafood. A Tom tip: prophylaxis is not started until weeks after the acute attack has settled. NSAIDs or colchicine may be used to prevent a gout attack during the initial period when starting prophylaxis. Once allopurinol or febuxostat is initiated, they can continue during further acute attacks. These facts are commonly tested in exams. Chapter 111: Pseudogout. Pseudogout is a crystal arthropathy caused by calcium pyrophosphate crystals collecting in the joints. It's formally known as calcium pyrophosphate deposition disease, or CPPD. It may also be called chondrocalcinosis. Let's talk about the presentation. The presentation of pseudogout varies. Many patients are asymptomatic and it's picked up incidentally on an X-ray. Others may present with chronic pain and stiffness in multiple joints. It can also present acutely with a rapid onset of symptoms. A typical acute presentation of pseudogout is a patient over the age of 65 with a rapid onset, hot, swollen, stiff, and painful knee. Other commonly affected joints are the shoulders, hips, and wrists. Let's talk about the diagnosis. In any patient presenting with a hot, painful, and swollen joint, septic arthritis or infection in the joint must be excluded, as this is a medical emergency. Symptoms of pseudogout tend to be milder than those of gout or septic arthritis. Joint aspiration is used to confirm the diagnosis. Aspirated joint fluid shows calcium pyrophosphate crystals. These are rhomboid-shaped and positively birefringent of polarized light. There should be no bacterial growth. Chondrocalcinosis is the classic X-ray change in pseudogout. The calcium deposits in the joint cartilage show up as a thin white line in the middle of the joint space. Other joint X-ray changes are similar to osteoarthritis, and these can be remembered with the loss mnemonic. L for loss of joint space, O for osteophytes, which are bone spurs, S for subarticular sclerosis, which is increased density of the bone along the joint line, and S for subchondral cysts, which are fluid-filled holes in the bone. Finally, let's talk about management. Treatment of pseudogout is targeted at the symptoms. There are no proven disease-modifying drugs, prophylactic treatments, or dietary modifications. Asymptomatic changes on an X-ray do not require any treatment. Acute symptoms usually resolve spontaneously over several weeks. Treatment options for acute symptoms include NSAIDs or non-steroidal anti-inflammatory drugs, such as naproxen, first line, and this is often co-prescribed with a proton pump inhibitor such as omeprazole for gastroprotection to protect the stomach. Other options are colchicine, intra-articular steroid injections. However, septic arthritis needs to be excluded before giving a steroid injection into the joint. And finally, oral steroids. Chapter 112: Osteoporosis. Osteoporosis involves a significant reduction in bone density. Osteopenia refers to a less severe decrease in bone density. Reduced bone density makes the bones weaker and prone to fractures. The World Health Organization provides definitions based on the T-score at the femoral neck, measured on a DEXA scan. The T-score is the number of standard deviations the patient is from an average healthy young adult. A T-score of -1 means the bone mineral density is one standard deviation below the average for a healthy young adult. A normal T-score at the hip is more than -1. Osteopenia is defined as a T-score at the hip of -1 to -2.5. Osteoporosis is less than -2.5, and severe osteoporosis is less than -2.5 plus a fracture. Let's talk about bone mineral density. Bone mineral density is measured using a DEXA scan, which stands for Dual Energy X-ray Absorptiometry. DEXA scans are a type of X-ray that measures how much radiation is absorbed by the bone, indicating the bone density. The bone mineral density can be measured anywhere on the skeleton, but the femoral neck reading is the most important. Bone density can be represented as a Z-score or a T-score. The Z-score is the number of standard deviations the patient is from the average for their age, sex, and ethnicity. The T-score is the number of standard deviations the patient is from an average healthy young adult. The T-score is used to make the diagnosis of osteoporosis. Let's talk about risk factors. The risk factors for osteoporosis are older age, postmenopausal women, reduced mobility and activity, a low body mass index or BMI under 19 kilograms per meter squared, a low calcium or vitamin D intake, alcohol and smoking, personal or family history of fractures, chronic diseases, for example, chronic kidney disease, hyperthyroidism, and rheumatoid arthritis, long-term use of corticosteroids, for example, 7.5 milligrams or more of prednisolone daily for longer than 3 months, and certain medications, for example, SSRIs, proton pump inhibitors, anti-epileptic drugs, and anti-estrogens. A Tom tip for you: estrogen is protective against osteoporosis, but estrogen drops significantly after the menopause. Hormone replacement therapy, or HRT, is protective against osteoporosis by adding in the missing estrogen. Tamoxifen is a selective estrogen receptor modulator, which is used in the treatment of breast cancer and it blocks estrogen receptors in breast tissue, but it stimulates estrogen receptors in the uterus and the bones. Therefore, it helps prevent osteoporosis by stimulating the estrogen receptors in bones, but it increases the risk of endometrial cancer by stimulating the estrogen receptors in the endometrium. Raloxifene is another selective estrogen receptor modulator which is used to treat osteoporosis. Next, let's talk about assessment. The NICE clinical knowledge summaries updated in April 2023 recommend assessing the following patients for osteoporosis: anyone on long-term oral corticosteroids, anyone with a history of a previous fragility fracture, anyone over 50 with risk factors, and all women over 65 and all men over 75. The 10-year risk of a major osteoporotic fracture or a hip fracture can be calculated using either the Q-Fracture tool, which is preferred by NICE, or the FRAX tool. And NICE say that the FRAX tool may underestimate the risk in some patients. Patients are categorized as low, intermediate, or high risk of fracture based on the risk calculator. For Q-Fracture, this is based on the percentage, and patients above 10% are considered for a DEXA scan to formally calculate their bone mineral density. For the FRAX tool, this is based on the NOG guideline chart, which is linked to on the online FRAX tool, which advises whether to arrange a DEXA scan or simply start treatment. These suggestions do not apply to certain groups of patients. For example, the NICE clinical knowledge summaries suggest a DEXA scan may be arranged without calculating the risk in patients over 50 with a fragility fracture, and treatment may be started without a DEXA scan in patients with a vertebral fracture. Next, let's talk about management. The first step is to address reversible risk factors. For example, increasing the physical activity, maintaining a healthy weight, stopping smoking, and reducing alcohol consumption. The second step is to address insufficient intake of calcium of less than 700 milligrams per day and inadequate vitamin D, for example, in patients with limited sun exposure, and this can be addressed with additional calcium of at least 1,000 milligrams daily and additional vitamin D of 400 to 800 international units daily. Bisphosphonates are the first-line treatment for osteoporosis. They're recommended for patients with osteoporosis based on a DEXA scan. They're considered in patients on long-term steroids to prevent osteoporosis. They work by interfering with the way that osteoclasts attach to bone, so they reduce the activity of the osteoclasts and reduce the reabsorption of bone. Bisphosphonates have some important side effects. These side effects include reflux and esophageal erosions, atypical fractures, for example, atypical femoral fractures, osteonecrosis of the jaw, so regular dental checkups are recommended before and during treatment, and osteonecrosis of the external auditory canal. Oral bisphosphonates, for example alendronic acid, are taken on an empty stomach with a full glass of water. Afterwards, the patient should sit upright for 30 minutes before moving or eating to reduce the risk of reflux and esophageal erosions. Examples of bisphosphonates are alendronate, 70 mg once weekly, and this is taken orally, risedronate, 35 mg once weekly, taken orally, and zoledronic acid, 5 mg, taken once yearly intravenously. The NICE clinical knowledge summaries recommend reassessing treatment with bisphosphonates after 3 to 5 years. They suggest a repeat DEXA scan and stopping treatment if the T-score is above -2.5. Treatment is continued in high-risk patients. There are many other specialist options for treating osteoporosis where bisphosphonates are not suitable, and these include denosumab, which is a monoclonal antibody that targets osteoclasts, romosozumab, which is a monoclonal antibody that targets sclerostin, a protein in osteocytes that inhibits bone formation, teriparatide, which acts in a similar way to parathyroid hormone replacement therapy with estrogen, particularly in women with early menopause, raloxifene, which is a selective estrogen receptor modulator, and strontium ranelate, which is a similar element to calcium that stimulates osteoblasts and blocks osteoclasts. A final note on some key side effects. Strontium ranelate increases the risk of venous thromboembolism and myocardial infarction. Raloxifene stimulates estrogen receptors in the bone, but not in the uterus or the breast. It increases the risk of venous thromboembolism. Chapter 113. Osteomalacia. Osteomalacia is a condition where defective bone mineralization causes soft bones. Osteo refers to bone, and malacia means soft. It's the result of insufficient vitamin D. The same process in children causes rickets. Let's go through some simplified pathophysiology. Vitamin D is a hormone the skin creates in response to sunlight. It's also obtained in limited amounts from food. It's vital in regulating bone mineralization, hormone secretion, and immune function. Low vitamin D is very common. Vitamin D is created from cholesterol in the skin in response to UV radiation. Patients with darker skin require more prolonged sun exposure to generate the same amount of vitamin D. It's also obtained from food as a fat-soluble vitamin. A regular diet does not contain enough vitamin D to compensate for reduced sun exposure. Patients with malabsorption disorders, for example inflammatory bowel disease, are at higher risk of vitamin D deficiency. Patients with chronic kidney disease are also at higher risk as the kidneys help convert vitamin D into its active form. Vitamin D is essential in calcium and phosphate absorption in the intestines and reabsorption in the kidneys. It's also responsible for regulating bone turnover and promoting bone reabsorption to increase the serum calcium level. Inadequate vitamin D leads to a low serum calcium and a low serum phosphate. Since calcium and phosphate are required for the construction of bone, low levels results in defective bone mineralization and osteomalacia. A low calcium level leads to increased parathyroid hormone secretion by the parathyroid glands, and this is called secondary hyperparathyroidism. Parathyroid hormone promotes calcium reabsorption from bones, so if there's increased parathyroid hormone, there's increased reabsorption of calcium from the bones, further impairing bone mineralization. A tom tip for you, most guidelines recommend against arranging a vitamin D blood test in asymptomatic patients with risk factors for deficiency. Those at risk are advised to take maintenance vitamin D supplementation without needing a test. Let's talk about the presentation of osteomalacia. Patients with vitamin D deficiency and osteomalacia may not have any symptoms. If they do have symptoms, typical symptoms include fatigue, bone pain, muscle weakness, muscle aches, and pathological or abnormal fractures. Looser zones are fragility fractures that go partially through the bone. One side of the bone is fractured and the other side of the bone is intact. A tom tip, consider vitamin D deficiency risk factors. Patients with osteomalacia are likely to have risk factors such as darker skin, low exposure to sunlight, living in colder climates, or spending most of their time indoors. Next, let's talk about the investigations. The serum 25-hydroxy-vitamin D is the laboratory investigation for vitamin D. Less than 25 nanomoles per litre indicates vitamin D deficiency, and 25 to 50 nanomoles per litre indicates vitamin D insufficiency. Other laboratory investigation results include a low serum calcium, a low serum phosphate, a high serum alkaline phosphatase, and a high parathyroid hormone, which is caused by secondary hyperparathyroidism. Imaging investigations include X-rays, which may show osteopenia or more radiolucent bones, and a DEXA scan will show reduced bone mineral density. Finally, let's talk about treatment. Treatment is with cholecalciferol, which is vitamin D3. There are various loading regimes, for example for patients with symptoms, that are suggested by the NICE clinical knowledge summaries from 2022. For example, 50,000 international units once weekly for 6 weeks, or 4,000 international units daily for 10 weeks. A maintenance dose of 800 to 2,000 international units per day is continued following the loading regime, or as the initial treatment in patients that do not require a rapid loading regime. The NICE clinical knowledge summaries recommend checking the serum calcium within a month of the loading regime. It may be low in calcium deficiency, high in primary hyperparathyroidism that was previously masked by the vitamin D deficiency, or high in other conditions that cause hypercalcemia, such as cancer, sarcoidosis, or tuberculosis. Chapter 114: Paget's disease of bone. Paget's disease of bone involves excessive bone turnover, both reabsorption and formation of bone, due to increased osteoclast and osteoblast activity. The excessive bone turnover is not coordinated, and this leads to patchy areas of high density, or sclerosis, and low density, or lysis. The result is enlarged and misshapen bones, structural problems, and an increased risk of pathological fractures. Paget's disease of bone particularly affects the axial skeleton, which are the bones of the head and the spine. The cause of Paget's disease of bone is unknown. It typically affects older adults. Let's start with the presentation. Patients may be asymptomatic, and it may be diagnosed incidentally on an X-ray, or it may present with bone pain, bone deformity, fractures, or hearing loss. Let's go through the investigations. X-ray findings include bone enlargement and deformity, osteoporosis circumscripta, which is well-defined osteolytic lesions that appear less dense compared with the normal bone, a cotton wool appearance of the skull with poorly defined patchy areas of increased and decreased density of bone in the skull, and V-shaped osteolytic defects in the long bones. Blood test results include a raised alkaline phosphatase, and this is the key blood investigation, a normal calcium, and a normal phosphate. Let's talk about management. Bisphosphonates are the mainstay of treatment for Paget's disease of bone. They are generally very effective. They interfere with osteoclast activity and restore normal bone metabolism. They improve symptoms and prevent further abnormal bone changes. Other measures include calcitonin, which is a treatment option where bisphosphonates are unsuitable, analgesia, for example, non-steroidal anti-inflammatory drugs if there's bone pain, calcium and vitamin D supplementation if necessary, and rarely surgery may be required to treat fractures, severe deformities, and arthritis. Monitoring the condition involves checking the serum alkaline phosphatase, or ALP, and reviewing the symptoms. Effective treatment should normalize the alkaline phosphatase result and eliminate the symptoms. Finally, let's talk about complications. The key complications to remember are hearing loss if it affects the bones of the ear, heart failure due to hypervascularity of the abnormal bone with extra blood vessels inside the abnormal bone, osteosarcoma, and spinal stenosis and spinal cord compression. Osteosarcoma is a type of bone cancer with a poor prognosis. It's a rare complication of Paget's. It presents with focal bone pain in a specific area, bone swelling, or pathological fractures. Spinal stenosis may occur where deformity in the spine leads to narrowing of the spinal canal. Pressure on the spinal nerves can cause neurological signs and symptoms. Spinal stenosis can be diagnosed with an MRI scan, and it may be treated effectively with bisphosphonates. Sometimes surgical intervention may be necessary. Chapter 115: Acute Kidney Injury. Acute kidney injury, or AKI, refers to a rapid drop in the kidney function, diagnosed by measuring the serum creatinine. Acute kidney injury is most common in acutely unwell patients, for example, patients with infections or following surgery. The NICE guidelines from 2019 give criteria for diagnosing an acute kidney injury, and these criteria are a rise in creatinine of more than 25 micromoles per litre in 48 hours, a rise of creatinine of more than 50% in 7 days, or a urine output of less than 0.5 milliliters per kilogram per hour over at least 6 hours. Let's go through the risk factors. The risk factors for acute kidney injury include older age, for example above 65 years, sepsis, chronic kidney disease, heart failure, diabetes, liver disease, cognitive impairment leading to reduced fluid intake, for example patients with dementia, medications, for example non-steroidal anti-inflammatory drugs or NSAIDs, gentamicin, and diuretics, and radiocontrast agents, for example contrast used in CT scans. Let's go through the causes. Let's start with a Tom tip. Whenever someone asks you the causes of an acute drop in kidney function, start with the causes are pre-renal, renal, or post-renal. This will impress them and allow you to think through the causes more logically. Pre-renal causes of acute kidney injury are the most common. Insufficient blood supply or hypoperfusion to the kidneys reduces the filtration of blood. This insufficient blood supply may be due to dehydration, shock, for example in sepsis or acute blood loss, or heart failure. Renal causes are due to intrinsic disease inside the kidney. This may be due to acute tubular necrosis, glomerulonephritis, acute interstitial nephritis, hemolytic uremic syndrome, and rhabdomyolysis. Post-renal causes involve obstruction to the outflow of urine away from the kidney, causing back pressure into the kidney and reduced kidney function. This is referred to as obstructive uropathy. Obstruction may be caused by kidney stones, tumors, for example retroperitoneal tumors, bladder tumors, or prostate cancer, strictures to the ureters or the urethra, benign prostatic hyperplasia, which is benign enlargement of the prostate, and neurogenic bladder, where there's a loss of nerve signal to the bladder causing retention of urine. Let's talk about acute tubular necrosis. Acute tubular necrosis refers to damage and death, or necrosis, of the epithelial cells of the renal tubules. It's the most common intrinsic cause of acute kidney injury. Damage to the kidney cells occurs due to ischemia due to hypoperfusion, for example, dehydration, shock, or heart failure, or due to nephrotoxins, or toxins that are harmful to the kidney, for example, gentamicin, radiocontrast agents, or cisplatin. Muddy brown casts on urinalysis confirm acute tubular necrosis. Renal tubular epithelial cells may also be seen on urinalysis. The epithelial cells of the renal tubules can regenerate, and this means that acute tubular necrosis is reversible, and recovery usually occurs within 1 to 3 weeks. Next, let's talk about acute interstitial nephritis. Acute interstitial nephritis is a common cause of acute kidney injury. It involves acute inflammation of the interstitium, which is the space between the tubules and the vessels in the kidney. This inflammation is caused by an immune reaction associated with drugs, for example, non-steroidal anti-inflammatory drugs or antibiotics, infections, for example, E. coli or HIV, or autoimmune conditions, for example, sarcoidosis or systemic lupus erythematosus. Other features of acute interstitial nephritis can accompany the acute kidney injury. Specifically, the features can include rash, fever, flank pain, and eosinophilia, or raised eosinophil count on the full blood count. Management involves treating the underlying cause, for example, stopping the non-steroidal anti-inflammatory drugs or treating the infection. Steroids may be used to reduce inflammation and improve recovery. Next, let's talk about the investigations used in an acute kidney injury. Urinalysis assesses for protein, blood, leukocytes, nitrites, and glucose in the urine. Leukocytes and nitrites suggest infection. Protein and blood suggest acute nephritis, but they can also be positive in infection. And glucose suggests diabetes. Ultrasound of the urinary tract can be used to assess for obstruction when a post-renal cause of acute kidney injury is suspected. Next, let's talk about management. Acute kidney injury is often preventable by avoiding nephrotoxic medications where appropriate, ensuring an adequate fluid intake, including IV fluids if the oral intake is inadequate, and additional fluids can be used before and after radiocontrast agents to prevent an acute kidney injury in patients having scans. Treating an acute kidney injury involves reversing the underlying cause and supportive management, for example, intravenous fluids to treat dehydration and hypovolemia, withholding medications that may worsen the condition, for example, NSAIDs and ACE inhibitors, withholding or adjusting medications that may accumulate with reduced renal function, for example, metformin and opiates, relieving the obstruction in a post-renal acute kidney injury, for example, inserting a catheter in a patient with prostatic hyperplasia or an enlarged prostate, and dialysis may be required in severe cases. Input from a renal specialist is required where there's a severe acute kidney injury, doubt about the cause, or complications. A Tom tip for you, calling ACE inhibitors nephrotoxic is incorrect. ACE inhibitors should be stopped in an acute kidney injury as they reduce the filtration pressure. However, ACE inhibitors have a protective effect on the kidneys long term. They're offered to certain patients with hypertension, diabetes, and chronic kidney disease to protect the kidneys from further damage. Finally, let's go through the complications. The complications of acute kidney injury are fluid overload, heart failure and pulmonary edema, hyperkalemia or raised potassium, metabolic acidosis, and uremia, which is a high urea level which can lead to encephalopathy and pericarditis. Chapter 116: Chronic Kidney Disease. Chronic kidney disease, or CKD, refers to a chronic reduction in kidney function sustained over 3 months. It tends to be permanent and progressive. Let's talk about the causes. Kidney function naturally declines with age. Various factors can speed up the decline and cause chronic kidney disease. The two most common causes of chronic kidney disease are diabetic nephropathy, or diabetes, or hypertensive nephropathy, or high blood pressure. Chronic high sugar levels passing through the glomerulus in patients with diabetes causes scarring, which is called glomerulosclerosis. Chronic high blood pressure causes scarring of the small vessels, the glomerulus, and the tubules, and this is called nephrosclerosis. Other common causes of chronic kidney disease include medications such as NSAIDs or lithium, glomerulonephritis, and polycystic kidney disease. Let's talk about glomerulosclerosis. Glomerulosclerosis describes scarring, or sclerosis, of the glomerulus. A key feature of glomerulosclerosis is proteinuria, with extra protein in the urine. Glomerulosclerosis can be caused by diabetic nephropathy, or diabetes, or focal segmental glomerulosclerosis. Focal segmental glomerulosclerosis involves patchy scarring of the glomerulus where specific or focal segments of the glomerulus are sclerosed, or scarred. It can be primary with no underlying cause, or secondary to causes such as drugs, for example anabolic steroids, or infections, for example HIV. Next, let's go through the presentation of chronic kidney disease. Most patients with chronic kidney disease are asymptomatic, meaning they have no symptoms and they wouldn't know they have the condition without testing. Signs and symptoms as the kidney function worsens are non-specific, and they can include things like fatigue or general tiredness, pallor or pale skin due to anemia, foamy urine, which is caused by protein in the urine, nausea, loss of appetite, pruritus or itching, edema due to fluid retention, hypertension or high blood pressure, and peripheral neuropathy due to damage to the nerves affecting the peripheries, particularly the feet. Next, let's talk about the investigations. The estimated glomerular filtration rate, or eGFR, is based on the serum creatinine, the patient's age, and their gender. The eGFR estimates the glomerular filtration rate, which is the rate at which fluid is filtered from the blood into Bowman's capsule of the nephron. Proteinuria, or protein in the urine, is quantified using a urine albumin-creatinine ratio, or ACR, and this is the ratio of albumin to creatinine. If the albumin level is high because lots of protein is being leaked out of the kidneys, the albumin-creatinine ratio will be raised. Hematuria, or blood in the urine, can be assessed using a urine dipstick or microscopy, looking at the urine under a microscope. Microscopic hematuria is when blood is identified on testing but is not visible on inspection with the eye of the urine. Macroscopic hematuria refers to visible blood in the urine. Hematuria or blood in the urine can indicate infection, malignancy, for example bladder cancer, glomerulonephritis, or kidney stones. It can also occur in polycystic kidney disease. Renal ultrasound can help identify obstructions, for example, kidney stones or tumours, and also polycystic kidney disease. Other investigations are necessary to identify risk factors, including the blood pressure for hypertension, HbA1c for diabetes, and a lipid profile for hypercholesterolemia. Next, let's talk about the classification. A diagnosis can be made when there are consistent results over at least 3 months of either an estimated glomerular filtration rate, or EGFR, sustained below 60 milliliters per minute per 1.73 meters squared, or a urine albumin creatinine ratio, or ACR, sustained above 3 milligrams per millimole. The G score is based on the EGFR. The A score is based on the albumin creatinine ratio. So a G stage of G1 is when the EGFR is above 90, G2 is when it's 60 to 89, G3A is when it's between 45 and 59, G3B is when the EGFR is 30 to 44, G4 is when it's 15 to 29, and G5 is when it's under 15. An A stage of A1 is when the albumin creatinine ratio is under 3 milligrams per millimole. A2 is when it's between 3 and 30, and A3 is when the albumin creatinine ratio is above 30 milligrams per millimole. Accelerated progression of chronic kidney disease is when there's a sustained decline in the estimated glomerular filtration rate, or EGFR, within 1 year of either 25% or 15 milliliters per minute per 1.73 meters squared. So accelerated progression is when there's a drop of either 25% or 15 points in the EGFR within 1 year. Next, let's go through the complications. The main complications of chronic kidney disease are anemia, renal bone disease, cardiovascular disease, peripheral neuropathy, end-stage kidney disease, and dialysis-related complications for patients on dialysis. Next, let's talk about management. The kidney failure risk equation can be used to estimate the 5-year risk of kidney failure requiring dialysis. The NICE clinical knowledge summaries updated in May 2023 suggest referral to a renal specialist when patients have an EGFR of less than 30, a urine albumin creatinine ratio of more than 70, accelerated progression, a 5-year risk of requiring dialysis above 5%, or uncontrolled high blood pressure or hypertension despite 4 or more antihypertensive drugs. Treating the underlying cause of chronic kidney disease involves optimizing diabetes control, optimizing hypertension control or blood pressure control, reducing or avoiding nephrotoxic drugs, and treating glomerulonephritis where this is the cause. The target blood pressure is less than 130/80 in patients under the age of 80 who have chronic kidney disease and an albumin creatinine ratio above 70 milligrams per millimole. If the albumin creatinine ratio is less than 70, then the normal blood pressure targets apply, which is typically less than 135/85 on home blood pressure readings. Medications that can help slow the disease progression in chronic kidney disease are ACE inhibitors or angiotensin II receptor blockers as an alternative to ACE inhibitors, SGLT2 inhibitors, specifically dapagliflozin, and finerenone. Reducing the risk of complications involves exercise, maintaining a healthy weight, and avoiding smoking, and atorvastatin 20 milligrams for primary prevention of cardiovascular disease, which is offered to all patients with chronic kidney disease. Management of complications involves oral sodium bicarbonate to treat metabolic acidosis, iron and erythropoietin to treat anemia, and vitamin D, a low phosphate diet, and phosphate binders to treat renal bone disease. And we'll talk about these complications and their management in more detail shortly. Management of end-stage renal disease involves special dietary advice, dialysis, and renal transplant. Let's talk in more detail about ACE inhibitors. ACE inhibitors are offered to all patients with chronic kidney disease with diabetes plus a urine albumin-creatinine ratio above 3, hypertension plus a urine albumin-creatinine ratio above 30, and all patients, including those who don't have diabetes or hypertension, who have a urine albumin-creatinine ratio above 70. In patients taking ACE inhibitors, the serum potassium level needs to be closely monitored, as both chronic kidney disease and ACE inhibitors can increase the potassium level and cause hyperkalemia. Next, let's talk about SGLT2 inhibitors in more detail. Dapagliflozin is the SGLT2 inhibitor that's licensed for the treatment of chronic kidney disease. It's offered to patients who have diabetes plus a urine albumin-creatinine ratio above 30. Dapagliflozin is considered for patients with diabetes plus a urine albumin-creatinine ratio of 3 to 30, and non-diabetic patients who have an albumin-creatinine ratio of 22.6 milligrams per millimole or above. Next, let's talk about finerenone. Finerenone is a non-steroidal mineralocorticoid receptor antagonist. NICE in 2023 recommended finerenone for patients with stage 3 or stage 4 chronic kidney disease, albuminuria, meaning high albumin levels in the urine, and type 2 diabetes, in addition to ACE inhibitors and SGLT2 inhibitors. Next, let's talk about anemia of chronic kidney disease. Healthy kidneys produce erythropoietin, which is a hormone that stimulates the production of red blood cells. Chronic kidney disease results in lower erythropoietin levels and a drop in red blood cell production. It causes a normocytic, meaning normal-sized, normochromic, meaning normal color, anemia. So in patients with anemia of chronic kidney disease, there are less red blood cells because the bone marrow is not being stimulated by erythropoietin, but the red blood cells are normal-sized and normal-colored. Anemia in chronic kidney disease may be treated with erythropoiesis-stimulating agents, such as recombinant human erythropoietin, essentially putting more erythropoietin into the system to compensate for the lower quantities produced by the diseased kidneys. Blood transfusions can sensitize the immune system, which is referred to as allosensitization, and this increases the risk of transplant rejection if the patient were to go on to have a kidney transplant in the future. Therefore, blood transfusions are avoided where possible. Iron deficiency is treated before using erythropoietin. An iron infusion given intravenously is usually given rather than iron tablets, particularly in patients who are having renal dialysis. Next, let's talk about renal bone disease. Renal bone disease is also known as chronic kidney disease mineral and bone disorder. It involves a high serum phosphate, low vitamin D activity, and a low serum calcium. Reduced phosphate excretion by the diseased kidneys results in high serum phosphate. Healthy kidneys metabolize vitamin D into its active form. Active vitamin D is essential in calcium absorption in the intestines and calcium reabsorption in the kidneys. Active vitamin D is also responsible for regulating bone turnover and promoting bone reabsorption to increase the serum calcium level. Therefore, chronic kidney disease leads to less vitamin D activity and a low serum calcium. The parathyroid glands react to the low serum calcium and the high serum phosphate by excreting more parathyroid hormone. This is called secondary hyperparathyroidism. Parathyroid hormone stimulates osteoclast activity to increase calcium absorption from the bone. Osteomalacia occurs in chronic kidney disease due to increased turnover of bone without an adequate calcium supply. Osteosclerosis, which is increased density of bone, occurs when the osteoblasts respond by increasing their activity to match the osteoclasts, creating new bone. Due to the low calcium level, this new bone is not properly mineralized, meaning it's not properly formed. A characteristic finding called Rugger Jersey spine on a spinal X-ray can occur in renal bone disease. This involves sclerosis, or more dense white, to the ends of the vertebral body, and osteomalacia with less dense white in the center of the vertebral body, and the name refers to the stripes found on a rugby shirt. Management of renal bone disease involves a combination of a low phosphate diet, phosphate binders to remove extra phosphate, active forms of vitamin D, specifically alpha-calcidol and calcitriol, and ensuring an adequate calcium intake. Osteoporosis can occur alongside renal bone disease, and this may be treated with bisphosphonates. Chapter 117: Dialysis. Dialysis is a method for performing the filtration tasks of the kidneys artificially. It's used in patients with end-stage renal failure or complications of an acute kidney injury. It involves removing excess fluid, solutes, for example potassium, and waste products from the blood, artificially replacing the function of the kidneys. Let's go through the indications for dialysis. The AEIOU mnemonic can be used to remember the indications for short-term dialysis. A for acidosis, when the acidosis is severe and not responding to treatment. E for electrolyte abnormalities, particularly treatment-resistant hyperkalemia or a raised potassium. I for intoxication, when there's overdose of certain medications. O for edema, where there's severe and unresponsive pulmonary edema with fluid collecting in the lungs. And U for uremia symptoms, or the symptoms of a high urea in the blood, such as seizures or reduced consciousness. The main indication for long-term dialysis is end-stage renal failure, or chronic kidney disease stage 5, with an estimated glomerular filtration rate, or eGFR, of less than 15. Let's talk about long-term dialysis. There are two options for dialysis in patients that require it long-term: hemodialysis and peritoneal dialysis, and we'll talk in more detail about both of these. The decision about which one to use is based on individual factors such as personal preferences, lifestyle, and comorbidities. Let's start with hemodialysis. With hemodialysis, patients have their blood filtered by a hemodialysis machine. Regimes can vary, but a typical regime might be 4 hours a day of hemodialysis, 3 days per week. Blood is taken out of the body, passed through the dialysis machine, and then pumped back into the body. The blood passes along a series of semi-permeable membranes inside the dialysis machine. Solutes are filtered out of the blood, across the membrane, and into a fluid called dialysate. The concentration gradient between the blood and the dialysate fluid causes water and solutes to filter out of the blood and across the membrane. Anticoagulation with citrate or heparin is necessary to prevent the blood from clotting while it's going through the machine. Hemodialysis requires good access to an abundant blood supply. 2 tubes are needed, one to remove the blood and one to put the blood back in. The options for long-term access are a tunneled cuffed catheter or an arteriovenous fistula. We're going to talk in more detail about both of these. Let's start by talking about a tunneled cuffed catheter. A tunneled cuffed catheter is a tube inserted into the subclavian or the jugular vein with a tip in the superior vena cava or the right atrium. It has 2 lumens, one for blood exiting the body, which is usually red, and one for blood entering the body, which is usually blue. Tunneled cuff catheters can stay in long-term and be used for regular hemodialysis. Something called a Dacron cuff surrounds the catheter, and this cuff promotes healing and adhesion or sticking to the tissues, making the catheter more permanent and providing a barrier to infection. The main complications of tunneled cuff catheters are infections and thrombosis, or blood clots inside the catheter. Next, let's talk about arteriovenous fistula. An arteriovenous or AV fistula is an artificial connection between an artery and a vein. The fistula bypasses the capillary system and allows blood to flow under high pressure from the artery directly into the vein. This provides a permanent, large, easy access vessel with high pressure arterial blood flow. Creating an AV fistula requires a surgical operation and a maturation period of 4 to 16 weeks before it can be used for dialysis. The options for AV fistulas are a radiocephalic fistula at the wrist, where the blood goes from the radial artery to the cephalic vein, a brachiocephalic fistula at the antecubital fossa on the inside of the elbow, which is where the blood goes from the brachial artery to the cephalic vein, and a brachiobasilic fistula at the upper arm, and this is less common and more complex. Features of an AV fistula to examine in an OSCE station are the skin integrity around the fistula, aneurysms with big bulges in the fistula. A palpable thrill is normal in the fistula, which is a fine vibration felt over the anastomosis or the join between the artery and the vein. And a machinery murmur is normal to be heard on auscultation using the stethoscope over the fistula. Complications of an AV fistula include aneurysms, infection, thrombosis, stenosis or narrowing, Steele syndrome, or high output heart failure. Steele syndrome occurs where there's inadequate blood flow to the limb distal or beyond the fistula. The AV fistula steals blood from the rest of the limb. Blood is diverted away from the part of the limb it's supposed to supply, leading to ischemia. Instead, blood flows through the fistula straight from the artery into the venous system. High output heart failure is caused by blood flowing quickly from the arterial system to the venous system through the AV fistula. There's a rapid return of blood to the heart, which increases the preload, or how full the heart is before it pumps. This leads to hypertrophy of the heart muscle, where the heart muscle grows because it's being filled with blood too quickly, and subsequently it leads to heart failure. A Tom tip for you: never take blood from a fistula. This fistula is a lifeline for the patient, providing dialysis access. If it gets damaged, it will set them back massively. Next, let's talk about peritoneal dialysis. Peritoneal dialysis uses the peritoneal membrane to filter the blood. A special dialysis solution containing dextrose is added to the peritoneal cavity, or the abdominal cavity. Ultrafiltration occurs from the blood across the peritoneal membrane into the dialysis solution contained within the peritoneal cavity. The dialysis solution is replaced taking away the waste products that are filtered out of the blood. Peritoneal dialysis involves a Tenkhoff catheter. A Tenkhoff catheter is a plastic tube inserted into the peritoneal cavity with one end on the outside so the dialysis solution can be added and removed. Continuous ambulatory peritoneal dialysis is where the dialysis solution is always inside the peritoneal cavity. There are various regimes for changing the solution, for example, 2 liters of solution replaced 4 times a day. Automated dialysis is the alternative to continuous ambulatory peritoneal dialysis. With automated dialysis, a machine continuously replaces the fluid in the peritoneal cavity for 8 to 10 hours overnight. Complications of peritoneal dialysis include bacterial peritonitis, which is infection in the peritoneal cavity and of the peritoneal membrane, and this is caused by the high sugar environment because dextrose solution is being added into the peritoneal cavity. Peritoneal sclerosis, which is thickening and scarring of the peritoneal membrane. Ultrafiltration failure, where the dextrose is absorbed, reducing the filtration gradient, making ultrafiltration less effective. Weight gain due to absorption of the dextrose in the fluid, and the psychosocial impact of having to perform peritoneal dialysis. Chapter 118: Renal Transplant. A renal transplant is where a kidney is transplanted into a patient with end-stage renal failure. It typically adds 10 years to life compared to just using dialysis, and it significantly improves the quality of life. Let's talk about donor matching. The patient and the donor kidneys are matched based on the human leukocyte antigen, or HLA, type A, B, and C on chromosome 6. They don't have to match fully, but the closer they match, the less likely there is for organ rejection to occur and the better the outcomes. In patients receiving a transplant from a living donor, they can receive treatment to desensitize them to the donor HLA in preparation for the transplant. Next, let's talk about the procedure. The patient's own kidneys are left in place. The donor kidney blood vessels are connected or anastomosed with the pelvic vessels, usually the external iliac vessels. The ureter of the donor kidney is anastomosed directly with the bladder. The donor kidney is left anteriorly or forward in the abdomen and can usually be palpated in the iliac fossa, in one side of the lower abdomen. A hockey stick incision is typically used and there will be a hockey stick scar. Next, let's talk about after the renal transplant. After the transplant, the new kidney will function immediately. Basiliximab is a monoclonal antibody that targets interleukin-2 receptors on T cells. 2 doses of basiliximab are given after the surgery to prevent acute rejection of the new kidney. Patients with a kidney transplant require lifelong immunosuppression to suppress the immune system and reduce the risk of transplant rejection, of the body rejecting the new kidney. There are various options and combinations of immunosuppressant medications, which may involve tacrolimus, mycophenolate, cyclosporin, azathioprine, and prednisolone. A Tom tip for you: when you're examining a patient with a renal transplant, you can look particularly clever by looking for the side effects of immunosuppressant medications to work out which ones the patient is taking. Generally, immunosuppressants cause seborrheic warts, which are skin lesions, and skin cancer, and you can look for scars from skin cancer removal surgery. Tacrolimus causes a tremor. Cyclosporin causes gum hypertrophy, where the gums become larger and more prominent. And steroids, for example prednisolone, cause features of Cushing's syndrome. Finally, let's talk about the complications. Complications relating to the transplant include transplant rejection, which can be hyperacute, acute, or chronic, transplant failure, and electrolyte imbalances. Complications relating to immunosuppressant medications include ischemic heart disease, type 2 diabetes, particularly caused by steroids. Infections are more likely, more severe, and may involve unusual pathogens, non-Hodgkin's lymphoma, and skin cancer, particularly squamous cell carcinoma. Unusual infections can occur secondary to the immunosuppressant medications, and examples of unusual infections are pneumocystis jirovecii pneumonia, or PCP, cytomegalovirus, or CMV, and tuberculosis, or TB. Chapter 119, Glomerulonephritis. Glomerulonephritis refers to inflammation of the glomeruli in the kidneys. The glomerulus is the first part of the nephron. It filters fluid out of the capillaries, out of the blood, and into the renal tubule. Glomerulonephritis describes the pathology that occurs in various diseases rather than being a disease itself. Treatment is targeted at the underlying cause and often involves supportive care and immunosuppression to reduce the inflammation, for example, corticosteroids. Let's talk about nephritic syndrome. Nephritis is a very generic term for inflammation in the kidneys. It's a descriptive term and not a diagnosis. Nephritic syndrome refers to a group of features that occurs with nephritis. These features are hematuria, which is blood in the urine, and this can be microscopic, meaning not visible to the naked eye, or macroscopic, meaning that it's visible just by looking at it. Oliguria, which is a significantly reduced urine output. Proteinuria, which is protein in the urine, but less than 3 grams of protein per 24 hours, and a higher protein content of the urine indicates nephrotic syndrome, which we'll talk about shortly. And finally, fluid retention. So let's talk about nephrotic syndrome. Nephrotic syndrome occurs when the basement membrane of the glomerulus becomes highly permeable, resulting in significant proteinuria. Normally, the basement membrane keeps proteins in the blood and stops them leaking out into the urine. With nephrotic syndrome, proteins are able to leak straight out into the urine. Nephrotic syndrome refers to a group of features without specifying the underlying cause. It involves proteinuria of more than 3 grams per 24 hours, a low serum albumin of less than 25 grams per litre in the blood, significant peripheral edema with fluid collecting under the skin, most notably in the legs, and hypercholesterolemia, or high cholesterol. Nephrotic syndrome presents with edema. Patients might notice frothy urine due to the high protein content. All the protein leaking out of the blood and into the urine predisposes patients to thrombosis, or blood clots, hypertension, or high blood pressure, and high cholesterol. The most common cause of nephrotic syndrome in children is called minimal change disease. This is usually idiopathic, meaning there's no identifiable cause, and treated successfully with steroids. The top causes of nephrotic syndrome in adults are membranous nephropathy and focal segmental glomerulosclerosis. Other causes of nephrotic syndrome include membranoproliferative glomerulonephritis, Henoch-Schönlein purpura, or HSP, diabetes, and infection, for example HIV. A Tom tip for you, minimal change disease comes up fairly frequently in exams as the most common cause of nephrotic syndrome in children. In a 2 to 5-year-old with edema, proteinuria, and a low albumin, the underlying cause of nephrotic syndrome is likely to be minimal change disease. Let's go through the types of glomerulonephritis. IgA nephropathy, which is also called Buerger's disease, is the most common cause of primary glomerulonephritis. What causes or triggers IgA nephropathy is unclear. The typical patient is in their 20s presenting with hematuria, or blood in the urine. Histology in IgA nephropathy shows IgA deposits and mesangial proliferation. The mesangial cells, which are what proliferate in IgA nephropathy, are found in the center of the glomerulus and they help support the capillaries, as well as performing other functions. Another cause of glomerulonephritis is membranous nephropathy, which involves deposits of immune complexes in the glomerular basement membrane, causing thickening and malfunctioning of the membrane and proteinuria, or protein in the urine. Histology shows IgG and complement deposits on the basement membrane. Membranous nephropathy is a key cause of nephrotic syndrome in adults. The majority, or around 70%, are idiopathic, meaning there's no clear underlying cause. It can occur secondary to malignancy, systemic lupus erythematosus, or medications, for example, nonsteroidal anti-inflammatory drugs, or NSAIDs. Another cause of glomerulonephritis is membranoproliferative glomerulonephritis, which is also called mesangiocapillary glomerulonephritis, and this typically affects patients under the age of 30 and involves immune complex deposits and mesangial proliferation. Another cause is post-streptococcal glomerulonephritis, which tends to affect patients under the age of 30. This presents 1 to 3 weeks after a streptococcal infection, for example tonsillitis or impetigo. Patients usually make a full recovery from post-streptococcal glomerulonephritis. Another cause is rapidly progressive glomerulonephritis, which is also called crescentric glomerulonephritis. This presents as an acute, severe illness but tends to respond well to treatment, and histology shows glomerular crescents. Another cause is Goodpasture syndrome, which is also known as anti-glomerular basement membrane or anti-GBM disease. Anti-GBM antibodies, or anti-glomerular basement membrane antibodies, attack the glomerulus and the pulmonary basement membranes in the lungs. Goodpasture syndrome causes glomerulonephritis and pulmonary hemorrhage with bleeding in the lungs. The typical presentation of Goodpasture syndrome is a patient in their 20s or their 60s with acute kidney failure and hemoptysis, or coughing up blood. Finally, systemic diseases that can cause glomerulonephritis include Henoch-Schönlein purpura, or HSP, vasculitis, for example, microscopic polyangiitis, or granulomatosis with polyangiitis, or lupus nephritis, associated with systemic lupus erythematosus. A Tom tip for you: if you come across a patient in your exams with significant renal impairment and hemoptysis, or coughing up blood, the top conditions to consider can be differentiated based on the antibodies. If they have anti-GBM antibodies, consider Goodpasture syndrome. If they have P-ANCA or MPO antibodies, consider microscopic polyangiitis. And if they have C-ANCA, also known as PR3 antibodies, consider granulomatosis with polyangiitis. Finally, let's talk about management. Diagnosis of glomerulonephritis typically requires a renal biopsy for histology. A renal specialist will guide treatment, which depends on the underlying cause. It may involve supportive care, for example, hypertension management and dialysis in severe disease, and immunosuppression, for example, with steroids. Chapter 120: Renal tubular acidosis. Renal tubular acidosis involves metabolic acidosis due to pathology in the tubules of the kidneys. The tubules balance hydrogen ions, or H+, and bicarbonate ions, or HCO3-, between the blood and the urine to maintain a normal pH of the blood. There are 4 types of renal tubular acidosis, each with different pathophysiology. To start with a basic summary, type 1 renal tubular acidosis is where the distal tubule cannot excrete hydrogen ions. The urinary pH is high and the serum potassium is low. Type 2 renal tubular acidosis is where the proximal tubule cannot reabsorb bicarbonate. The urinary pH is high and the serum potassium is low. And type 4 renal tubular acidosis is where there's a low aldosterone or impaired aldosterone function, the urinary pH is low and the serum potassium is high. And we'll go into more detail about how these work shortly. A Tom tip for you, remember type 1 and type 4 for your exams. Type 4 is the most common type. Both type 1 and type 4 involve inadequate excretion of hydrogen ions in the distal tubules. In type 1, there is hypokalemia, or a low potassium, and in type 4, there is hyperkalemia, or a raised potassium. So let's talk in more detail about type 1 renal tubular acidosis. Type 1 renal tubular acidosis, which is also called distal renal tubular acidosis, occurs when the distal tubule in the nephron cannot excrete hydrogen ions into the urine. This results in a high urinary pH above 6 due to the absence of hydrogen ions in the urine, a metabolic acidosis where the blood is acidotic due to retained hydrogen ions in the blood, and hypokalemia, or a low potassium, due to failure of the hydrogen and potassium exchange in the distal tubule. The hydrogen-potassium ATPase pump is what uses ATP to pump hydrogen into the urine and potassium into the blood in the distal tubule. This fails in type 1 renal tubular acidosis, meaning that less hydrogen is pumped into the urine and less potassium is brought back into the blood. Many conditions can cause this pathology in the distal tubule, leading to type 1 renal tubular acidosis, including genetic causes, and there's both autosomal dominant and autosomal recessive forms, systemic lupus erythematosus, Sjogren syndrome, primary biliary cholangitis, hyperthyroidism, sickle cell anemia, and Marfan syndrome. Type 1 renal tubular acidosis presents with failure to thrive in children, recurrent urinary tract infections due to the alkaline urine, bone disease, specifically rickets or osteomalacia, muscle weakness, and arrhythmias due to the hypokalemia or low potassium. Treatment of type 1 renal tubular acidosis is with oral bicarbonate, which corrects the acidosis and the electrolyte imbalances. Next, let's talk about type 2 renal tubular acidosis. Type 2 renal tubular acidosis, which is also called proximal renal tubular acidosis, occurs when the proximal tubule cannot reabsorb bicarbonate from the urine to the blood, with excessive bicarbonate excreted in the urine. This results in a high urinary pH above 6 due to the excess bicarbonate in the urine, a metabolic acidosis with acidotic blood due to inadequate bicarbonate in the blood, and hypokalemia or low potassium due to urinary loss of potassium along with the bicarbonate. The key causes of type 2 renal tubular acidosis are inherited, and it can be autosomal dominant or autosomal recessive, multiple myeloma, and Fanconi syndrome. Treatment of type 2 renal tubular acidosis is with oral bicarbonate. Next, let's talk about type 3 renal tubular acidosis. Type 3 renal tubular acidosis, which is also called mixed renal tubular acidosis, is a combination of type 1 and type 2, with pathology in the proximal and the distal tubules. This is rare and it's unlikely to appear in exams, so you don't need to know much about this condition. Finally, let's talk about type 4 renal tubular acidosis. Type 4 renal tubular acidosis, which is also known as hyperkalemic renal tubular acidosis, is caused by reduced aldosterone activity in the kidneys. Aldosterone normally acts on the distal tubules to stimulate sodium reabsorption from the urine to the blood, potassium excretion in the urine, and hydrogen ion excretion in the urine. Therefore, low aldosterone or impaired aldosterone function in type 4 renal tubular acidosis leads to increased excretion of potassium and hydrogen ions in the urine. Normally, ammonia is produced in the proximal tubule to balance the excretion of hydrogen ions. Ammonia is a base and it buffers the hydrogen ions, preventing the urine from becoming too acidotic. Hyperkalemia, or a high potassium, suppresses ammonia production, so the urine becomes acidic. To summarize, the results of type 4 renal tubular acidosis are metabolic acidosis due to retained hydrogen ions in the blood causing the blood to become acidotic, hyperkalemia or raised potassium in the blood due to retained potassium in the blood, and a low urinary pH, meaning the urine is acidic due to reduced ammonia production in response to hyperkalemia. Low aldosterone or low aldosterone activity can be due to adrenal insufficiency, where the adrenal glands fail to produce the aldosterone, diabetic nephropathy, where diabetes has damaged the kidneys, and medications, for example, ACE inhibitors, spironolactone, or eplerenone. Management of type 4 renal tubular acidosis is targeted at the underlying cause. Fludrocortisone, which is a mineralocorticoid steroid medication, can be used to replace the aldosterone in aldosterone deficiency. Oral bicarbonate and treatment of hyperkalemia may also be required. Chapter 121. Hemolytic uremic syndrome. Hemolytic uremic syndrome, or HUS, involves thrombosis, or blood clots, in the small blood vessels throughout the body, usually triggered by the Shiga toxin, which can come from E. coli 0157 or Shigella. Hemolytic uremic syndrome most often affects children following an episode of gastroenteritis. Antibiotics and antimotility medications, for example loperamide, used to treat gastroenteritis caused by E. coli 0157 or Shigella, increase the risk of hemolytic uremic syndrome. Hemolytic uremic syndrome leads to the classic triad of features of microangiopathic hemolytic anemia, acute kidney injury, and thrombocytopenia, or low platelets. Microangiopathic hemolytic anemia, or MAHA, involves the destruction of red blood cells, or hemolysis, due to pathology in small blood vessels. Tiny blood clots, or thrombi, partially obstruct the small blood vessels and churn up the red blood cells as they pass through, causing the red blood cells to rupture, leading to anemia. The formation of blood clots throughout the small blood vessels consumes platelets. It uses up the platelets, and this leads to a low platelet count, or thrombocytopenia. The blood flow through the kidneys is affected by the small blood clots and the buildup of damaged red blood cells, and this leads to acute kidney injury. Let's talk about the presentation. E. coli 0157 and Shigella cause gastroenteritis. Diarrhea is the first symptom, which turns bloody within 3 days. The features of hemolytic uremic syndrome develop around a week after the onset of diarrhea, with fever, abdominal pain, lethargy, pallor or pale skin, reduced urine output or oliguria, hematuria with blood in the urine, hypertension or raised blood pressure, bruising due to the low platelet count, jaundice or raised bilirubin, which causes yellowing of the skin and the sclera in the eye, which is caused by the breakdown of red blood cells or hemolysis releasing bilirubin into the blood, and confusion. Finally, let's talk about management. Stool tests, for example, culture and PCR tests, are used to establish the causative organism, whether that's E. coli 0157 or Shigella. Hemolytic uremic syndrome is a medical emergency and it requires hospital admission and supportive management, with treatment of hypovolemia or dehydration with IV fluids, treatment of hypertension or raised blood pressure, treatment of severe anemia, for example with blood transfusions, and treatment of severe renal failure, for example with hemodialysis. Hemolytic uremic syndrome is self-limiting and most patients fully recover with good supportive care. Chapter 122: Rhabdomyolysis. Rhabdomyolysis involves skeletal muscles, or the muscles attached to the skeleton, breaking down and releasing various chemicals into the blood. Muscle cells, which are called myocytes, undergo cell death, which is called apoptosis, and this results in them releasing myoglobin, potassium, phosphate, and creatine kinase. Potassium is the most immediately dangerous breakdown product from muscle cells. Hyperkalemia, or a high potassium level in the blood, can cause cardiac arrhythmias and cardiac arrest. These breakdown products can cause acute kidney injury with an acute onset of reduced kidney function. Myoglobin in particular is toxic to the kidneys in high concentrations. Impaired renal function or kidney function results in further accumulation of these substances in the blood. Other complications of rhabdomyolysis include compartment syndrome and disseminated intravascular coagulation. Let's go through the causes. Anything that causes significant damage to muscle cells can cause rhabdomyolysis. For example, prolonged immobility, particularly in frail patients who fall and spend a long time on the floor before they're found, extremely vigorous exercise beyond the person's fitness level, for example, endurance events or CrossFit competitions, crush injuries where the muscles are crushed, seizures, and rarely statins. Let's talk about the signs and symptoms. The presenting features of rhabdomyolysis can include muscle pain, muscle weakness, muscle swelling, reduced urine output or oliguria, red-brown discoloration to the urine caused by myoglobinuria or myoglobin in the urine, fatigue, nausea and vomiting, and confusion, particularly in frail patients. Let's talk about the investigations. Creatine kinase, or CK, is the crucial diagnostic test for rhabdomyolysis. Creatine kinase is normally less than about 300 international units per litre in the blood. In rhabdomyolysis, it can be 1,000 or even 100,000 international units per litre. It typically rises in the first 12 hours after the muscle damage, remains elevated for 1 to 3 days, and then gradually falls. The higher the creatine kinase level, the greater the risk of kidney injury. Myoglobinuria refers to myoglobin in the urine, which gives the urine a red-brown color. A urine dipstick test will be positive for blood. Urea and electrolytes, or U's and E's, on the blood test are required to diagnose acute kidney injury and hyperkalemia, or raised potassium. ECGs are used to assess and monitor the heart's response to hyperkalemia, or raised potassium. Finally, let's talk about management. Intravenous fluids are the mainstay of treatment for rhabdomyolysis, and these are used to correct hypovolemia, or reduced volume of fluid in the blood, and encourage filtration of the breakdown products in the kidneys. You can think of the purpose of intravenous fluids as to flush out all the breakdown products in rhabdomyolysis. Treatment of complications, particularly hyperkalemia, is also essential. Additional options that are debatable and have associated risks include using intravenous sodium bicarbonate to increase the urinary pH and reduce the toxic effects of myoglobinuria, and intravenous mannitol to increase urine output and reduce edema. Chapter 123: Hyperkalemia. Hyperkalemia refers to a raised serum potassium, a raised potassium level in the blood. The main complication of hyperkalemia is cardiac arrhythmias such as ventricular fibrillation, which can lead to cardiac arrest. Let's go through the ranges for the serum potassium levels and what they mean, and the units for these levels are millimoles per litre. A normal range for potassium is 3.5 to 5.3. Mild hyperkalemia is 5.4 to 5.9. Moderate hyperkalemia is 6.0 to 6.4, and severe hyperkalemia is 6.5 and above. Let's go through the causes of hyperkalemia. Conditions that can cause a raised serum potassium include acute kidney injury, chronic kidney disease, typically stage 4 or 5, rhabdomyolysis, adrenal insufficiency, and tumor lysis syndrome. There are 4 classes of medications that can cause a raised serum potassium, and these are worth remembering. Aldosterone antagonists, for example, spironolactone and eplerenone, ACE inhibitors, for example, ramipril, angiotensin II receptor blockers, for example, candesartan, and nonsteroidal anti-inflammatory drugs, or NSAIDs, for example, ibuprofen or naproxen. Hemolysis, which is the rupture of blood cells, which occurs during blood sampling, can give a falsely elevated potassium, which is known as pseudohyperkalemia. The lab might indicate that they've noticed hemolysis in the sample and recommend a repeat sample to get an accurate potassium level. Next, let's go through the ECG changes that occur with hyperkalemia. The ECG changes with hyperkalemia are important to remember, and they are tall, peaked T waves, flattened or absent P waves, prolonged PR interval, and broad QRS complexes. Finally, let's talk about the management of hyperkalemia. Each hospital will have a policy and protocol to follow for patients with hyperkalemia. There should be input from experienced seniors, including the intensive care team for severe hyperkalemia and renal physicians for renal impairment. Management of serum potassium levels below 6.5 millimoles per litre without ECG changes is aimed at treating the underlying cause, for example, treating acute kidney injury and stopping causative medications, for example, spironolactone or ACE inhibitors. Patients require urgent treatment for hyperkalemia to bring the potassium level down if they have either ECG changes or a serum potassium level above 6.5 millimoles per litre. The mainstay of treatment is with an insulin and dextrose infusion and IV calcium gluconate. These are the 2 treatments to remember for hyperkalemia. Insulin drives potassium from the extracellular space, which is the space in the body outside the cells, including the blood, to the intracellular space. So it takes potassium out of the blood and into the cells. Dextrose is required alongside the insulin to prevent hypoglycemia, which is a low glucose level caused by the insulin taking glucose out of the blood. Calcium gluconate stabilizes the cardiac muscle cells and reduces the risk of arrhythmias. Other options for lowering the serum potassium are nebulized salbutamol, which temporarily drives potassium into cells, oral calcium resonium, which reduces potassium absorption in the gastrointestinal tract, but this is slow and it causes quite bad constipation. Sodium bicarbonate in acidotic patients on renal advice drives potassium into cells as it corrects the acidosis, and hemodialysis may be required in severe or persistent cases.